Great. I think we are now,
Now live.
live. So thank you and good morning, everybody. Warm welcome to you all to our public meeting of Northamptonshire Healthcare NHS Foundation Trust. Delighted to welcome any governors and members of the public who are watching live, or indeed who are watching us back, because people do watch the video that is available to people after we've recorded this meeting. So just to remind all colleagues that the meeting is being recorded and will remain available for viewing. And and just really welcome everybody. We've had a couple of apologies this morning. David Mayer, Deputy Chief Executive and Managing Director, and David Williams, Group Director of Strategy and Partnerships. We were hoping, I think Alison Gilmore would be able to attend to deputise for David Williams, but she's been unable to this morning at this stage. She may well join at some point during the meeting. So if there are any items that don't think, yes, I mean, I think what we can do is just sort of take questions in relation to any of the reports that are associated, particularly Digby Q, I guess the strategy report is the main one that we would have expected one of our colleagues to present, but we can note some questions and comments on that. And I'm sure colleagues who own those objectives will also be able to respond as we go through. So we'll make a start on the formal items on our agenda. So declarations of interest. Just to mention, I think Saqib, did you want to mention your new appointment?
Yeah, I was just going to mention that. So as many colleagues will be aware, my term will be coming to an end in December. And in parallel, I've managed to secure a role with Queen Elizabeth Hospital King's Lynn as NED and Audit Chair. So that started on Monday. So there'll be a period of overlap, but just to declare that. So there should be no conflicts. Though seeing this morning, areas are emerging left, right, and centre. So there's a group model being adopted between CCS and Norfolk that was announced in NHFT this morning. So there shouldn't be any conflicts, but obviously I will declare them if there are any.
Thank you very much, Saqib. Congratulations. Really pleased for you, really positive. So thank you for mentioning that. There's an opportunity, obviously, if anyone's got any declarations of interest in relation to items on the agenda, to declare that now. Otherwise, clearly just to keep our register of interests up to date. That's the general principle really that we operate on. So minutes of the previous meeting held on the 30th of May, which is paper A. Can I just check with everybody if they're content that the minutes are accurate, and if so, whether they're happy to sign those off? I'll take that as a yes if there are no points of accuracy. So paper A, minutes approved. Are there any matters arising that aren't covered in our action sheet? Okay, so we'll move on to action sheet paper B, which, just checking, I think Richard and I, certainly on FT 2451, which is links to the prison healthcare strategy and the discussion, the excellent patient story that we had at the last board. I think, Richard, we're planning to include a discussion on our prison contracts and approach in August. I think that's the conversation we've had.
Indeed, Krishna, yes, at the August workshop.
Great. So that's the plan at the moment, and I think we can also weave in the first point in that action sheet about how best to influence prison healthcare strategy as part of that. But it is an action outstanding for David at the moment. Risk report, I think that's been included in the risk paper, so we'll come on to that. And the other actions, FT 2459, are completed. FT 2463, which was the question around timescales for completion for work at Marina. I actually couldn't see any reference to this anywhere in the documentation. So, Paul, are you able to comment on that? I see you put your hand up.
I am Krishni, and the reason it's not in the documentation is all the documentation was produced before we had the final outcome.
Okay.
So we're now working on a timescale that before the end of September, Marina should be back up and operational, and all of the work carried out. It has already started actually, so we should be in a relatively short period of time to get that work done.
And Paul, the context for that was clearly, the patient impact, but also the financial impact, because I think there was a sort of reference in the organisational performance report around out of area placements,
That's
and
right.
of course that has a consequential impact. So, what's your sense of how we're managing that? And do you want to pick that up later? I mean, I'm quite happy.
Well, I can pick it up now, Krishna, because there's a series of dominoes really that one leads to the next. So the damage to Marina as an environment was substantial. It's a patient who was particularly unwell. We managed operationally and clinically to deal with patients that were on the ward, discharges planned, but actually on advice, it was clear that the extent of the damage needed some downtime. So that is why we're seeing the outflows in terms of the costs for patients elsewhere, predominantly with St Andrews, and that is a cost pressure, and if we have to find mitigations, which I can expand on later, Christian. One thing that has been slightly frustrating is because it's through the PFI provider, it's taken quite a time for everything to be drawn up in terms of contracts and then the lenders to agree it. And it's the last point which has taken a lot longer than we'd thought. But we have it all in place now. And as I said, the work has already started. So all of those things do link together, unfortunately.
Okay, thank you, Paul. Really helpful to understand that a bit more. Okay, the remaining actions, FT 2468, that was completed. I think that schematic went to Integrated Assurance Committee in June. And the only other item, well, the annual effectiveness review of the board and its committees, I think this was about adjusting the questions once we'd got the well-led report, and we have now received it and are considering it, aren't we, Richard? So again, is this something we could just briefly discuss at our August workshop?
That's certainly the plan, Christy, yes.
Okay, great. And then finally, we had an outstanding action, Paul, around the estate strategy and bringing back the an annual estates plan. It was obviously outstanding because of the financial allocations not being on capital allocations not being.
Which was then further derailed by the national announcements about systems that didn't have a balanced plan being further having their capital budgets further curtailed by 10%. So again, that's why we're not back here today. Execs haven't had the opportunity to consider what the plan is. So unfortunately delayed again.
Yeah. So we'll pick that up perhaps at the next meeting. Do you think that's a reasonable timescale, Paul?
I think that's highly likely, Christian.
Yeah. Okay. Thank you very much. So we'll keep that on our action sheet for now and revisit that. But I think, have covered now all of the actions that were outstanding. So thank you very much for those updates. We also have paper C, which is our annual forward plan, just for noting really, but obviously if any colleagues have got any questions or comments on items that are coming up or due, then happy to note them now. But if we haven't got anything else, then we are able to move on to our patient and staff story, and really delighted to be welcoming Simon and Marie. But Anne, I think you're probably going to introduce this in the customary way. So we'll hand over to you and look forward to hearing from colleagues. Thank you.
Yes, thank you, Krishni. So today we are going to be looking particularly at our CAMS service, our inpatient service. This came from really some really phenomenal stories of patients progressing and having really life-changing experiences through working with our teams and with the wider collaborative that we have, as we are the lead in the CAMS provider collaborative. So Simon's come from the collaborative point of view today to talk about the work that does and how we work in the East Midlands. And Marie is our service manager for inpatients, and she's just going to bring to life what that means for people who use our services, and also what that means for our staff who work within those services, seeing such transformational changes for our population. So really excited to hear what they've brought today. I mean, it could be one of so many stories, which I think is really quite powerful. But I will hand you over to Marie and Simon to just share the work that they've been doing.
Morning everyone, my name's Marie James. I'm the service manager for CAMS Inpatients, IoT, Crisis and the Residential Short Break Service. I'm just going to share my screen. Okay, can everybody see that? Okay, so today I'm here to share with you Liv's story. So just to give you some background, Livy was a 12-year-old girl when she was initially referred into NHFT school nursing, and that was by her school in June 2022. She'd lost some weight and her general mood and presentation had dipped. Following a face-to-face appointment with the school nursing team, it was identified that she had actually lost 4 kilograms since being weighed at school in May 2022. And we do see a little bit of a pattern with some of our young people where that year 6 screening programme has a real profound effect on them. So at that point, she was 38 kilograms. School nursing referred into the community children's eating disorder team, and they offered an extended assessment and requested that school nursing support with some kind of OCD traits that they saw. She did put on some weight and she was discharged from KEDS back into the care of her GP in September 2022, and the weight monitoring continued. But by November, we were again seeing a pattern of weight loss, really struggling with emotional health and well-being, and lots more obsessive behaviours. She was referred back into KEDS, and things were quite difficult at the time. So they advised no school, no exercise, and she commenced some refeeding. And initially her weight did start to increase. So they started some family-based treatment and then referred into CAMS for some support around the OCD type presentation. CAMS declined the referral and Livy continued to kind of deteriorate. There was severe restriction. She was drinking excessive amounts of water. There was lots of physical aggression to mum and some harm to herself. And by the end of January 2023, things were getting really, really difficult. And KEDS referred her into CAMS inpatients. Now, for our under 13s, they would go to the Children's Network, and they have provisions kind of across the country, but there isn't any local to us. So the referral went to the network and Livy was offered a bed in Liverpool in an under 13s ward, and at which point her weight was down to 34 kilograms.
Marie, sorry to interrupt. Is it possible to put it on full screen? Because we can see it, but that's it. That's better. Is that better for everybody? Great. Thank you, Marie. Sorry to interrupt.
No problem. So in terms of the provider collaborative, so Livy was in the under 13s hospital from February 2023 through to July 2023, where she got a diagnosis of anorexia nervosa during her admission. She was allocated a case manager from the provider collaborative, and their role is kind of to quality assure the journey through CAMS inpatients. The case manager attended her CPA meetings. She had regular communication with the ward regarding her presentation. But towards July, it became apparent that Liv would not be ready for discharge, and she was due to become 13 in September 2023. The Children's Network beds are up to the age of 13. So Liv was referred into Northamptonshire CAMS inpatients for access assessment. The provider collaborative played a vital role in this referral process. The case manager met with the service manager, which is myself, and the ward manager, to discuss the case and kind of advocate for the young person. It became really clear that Liv had a real complex presentation and therefore needed careful consideration and a more bespoke package. At the point of referral, Liv was detained under Section 3 of the Mental Health Act. She was not taking any oral food. She was requiring restraint nasogastric tube feeding by a team of staff who needed to wear protective clothing. Post-feed seclusion was required for aggression towards staff, and Liv had been presenting with high levels of risk towards self after her feed, trying lots of ligatures, head banging and scratching herself. Liv had been refusing all medication and was also requiring periods of time in extra care, which is where you're nursed alone. And other than weight restoration, which they had managed to restore weight up to 40.6 kilograms, Liv had not made any progress towards discharge. She was unable to go on home leave or have any leave off the ward. So Liv was referred to the Burrows, which is a 10-bed CAMHS GAU on the Berrywood site. They completed Liv's access assessment, and she was access assessed as requiring paediatric intensive care. And this is due to the level of aggression towards staff and the level of restraint and daily seclusion. Liv's complex presentation presented us with a real challenge to the other CAMHS pathways. She was 12 years old at point of referral, so the access assessing team believed a low secure admission would not be in her best interest. A PQ admission is often offered for short-term stabilisation where there's significant risk, and it was clear that Liv may need an extended admission to be able to reintegrate successfully into the community. Considering the lack of options for Liv and the possible outcomes for her, the Burrows agreed to consider Liv for admission if they could be supported by the provider collaborative using an extra package of care. This allowed the Burrows to provide the additional staffing that Liv would need to reduce the bed numbers and to ensure that there was an available space should Liv need a reduced stimulation environment. So on admission to the Burrows, I'm just going to bring all this through so that I don't have to keep interrupting. So on admission to the Burrows, it became evident that Liv would need a very high level of support around feeding. She continued to refuse all oral nutrition. Despite the Burrows having extensive experience in NG feeding under restraint, Liv's feed was extremely difficult for both her and the staff members. 10 staff were required to feed safely using a restraint technique and a safety pod. Liv became highly distressed. Pre-feed, she would get underneath furniture or wrap herself around items. The feed was carefully planned around education times so that the other young people were not on the ward. The dietitian worked with the team to enable the team to do 1 feed per day due to the duration and intensity. Transferring Liv to seclusion was unsafe following feeds, as she would have required a lift across distance while resistive, which would increase the risk of injury to staff post-feed. Liv could be distressed for up to 2 hours post-feed where staff were targeted. Liv's risk assessment and care plan needed review and update daily. The team needed to positive risk take and think creatively. The risks pushed the boundaries of many of our trust policies, especially around manual handling, as the only way to safely feed Liv was to lift her into the safety pod. We had multiple escalation meetings to discuss the level of risk the Burrows were managing. We watched hours of body-worn camera footage to perfect the restraint intervention and try and protect our staff on disengaging. Staff were significantly injured during daily restraints. Staff needed high levels of support and supervision. We purchased protective equipment for staff to try and prevent some of the biting and scratching, as staff were getting severe infections into their wounds. Outside of feeding, Livy was able to engage with some of the programme on the ward. She was able to build up some leave and access some of the activities she had prior to her admission. Liv refused most personal care, including brushing teeth and showers. Through a period of assessment, Liv's clinical team were querying if she may be neurodivergent. The team started using techniques to help and support her, such as positive behaviour support, structure routine boundaries, and reducing stimulus where possible. They also promoted engagement in meaningful activity. Liv was reluctant to engage in psychological therapy, but did engage well with her nursing team. For consistency, this was key senior nurses with experience in ASD and LD, and they were able to offer one-to-one sessions. Liv had an ASD assessment, which was inconclusive. Mum engaged really well with family therapy, and over a period of months, Livy worked hard with the staff to try and reduce some of the restriction during feeds. Livy was prescribed medication and reviewed regularly by the ward consultant. The ward consultant was creative and flexible with leave to enable Livy to start re-engaging with her community and living life outside of a hospital setting. I just wanted to kind of pick up on some of the partnership working that was involved during Liv's case. So the PMVA team just played a vital role in supporting the ward to safely manage feeding Livy. They spent hours observing restraints or being part of the restraint team or watching back body-worn camera footage and offering us advice and support to try and keep Livy and staff safe. They supplied additional body-worn cameras for us. And there was huge adjustment made. So I can't kind of thank the PMVA team enough, because what they did was invaluable for the boroughs. The manual handling team also were involved. They came to the ward to support and to contribute to her care planning around her manual handling techniques. And as her feed did involve a lift, that was a real challenge in terms of our trust policy, but we were supported. And obviously this is a life-saving technique that we were delivering. The Berrywood Hospital site, so adult mental health services, were extremely supportive. At one point, we weren't making any progress, and we really wanted to test whether it would be more helpful to have a separate restraint team coming in to kind of promote that therapeutic from the ward staff. And adults hugely supported us in delivering that. It wasn't successful, but it really helped us in understanding how to move forward. We've had huge help from our senior management and leadership team, and that's across the board from all of our managers. I know Annie's often pops down to the boroughs just to check in, and that was really helpful because her presentation was really complex. We had a real balance of preserving life against the balances of risk and safety, and that was a challenge to us across the trust. So the leadership team, supported by kind of approving all of our WEP requests that came through, visiting the ward and just checking in on our staff and managers. Unfortunately, 6 months into Liv's submission, there was a real deterioration in her presentation. Her risk increased to self and others, and the feed became more challenging and again required us to go up to 10 staff. It was really difficult. She was secreting items to use as ligatures. There was 2 hours post-feed of significant risk to self and others, supine restraint being needed to commence the feed, lots of physical and verbal aggression, significant injuries to staff, intense screaming, scratching and biting staff, and we had lots of staff that had to go to occupational health where there was infection. She was unable to access leave and no longer engaging in some of those activities she really loved, and unfortunately was in rip-proof clothing. The boroughs were really struggling, the staff team was exhausted, and the impact was really significant. Liv was stuck in a similar position to before, although more weight restored, but not making any further progress towards discharge. And the team had to make the real difficult decision to refer Liv for a low secure admission, accepting that a different approach may be needed. Livy was referred to St Andrew's Hospital, and there was a delay, which looking back now is really fortunate in when they would be able to accept her. So in May 2024, so not that long ago, we just had this real fantastic turning point for Liv. She voiced to some staff over a weekend that she really fancied eating, and it was something like chips that she really wanted. And the staff were kind of, just go for it, just go for it. And she started eating orally, and she continued eating orally from that point. There was no more restraint feeding from that point. She was able to come out of rip-proof clothing. She started to be a bit more future orientated. She engaged with a discharge plan, started home leave, including an overnight stay, which had never happened. Remembering we're talking back in 2022 when the difficulties started, and she was early in hospital. So she's been in hospital for well over a year. The Burrows ward started to help her with her personal care and personal hygiene, and she's engaged in that. She's accessed a dentist and is brushing her teeth twice a day. This young lady had not brushed her teeth or been to a dentist in 2 years. The boroughs have referred Liv into the CAMHS intensive outreach team, and they're able to work intensively with Liv at home on discharge. The team have been visiting her on the ward to get to know her. and they can offer step down and emissions avoidance, and they're also commissioned by the provider collab. Core CAMS have now accepted Liv's referral, and she's also open to the physical health team for monitoring on discharge. The boroughs have worked tirelessly to ensure everything is in place for discharge, promoting completion of 117, aftercare plan, and negotiating a bespoke crisis plan. The borough's manager has been to panel, and 30 hours a week have been approved through social services for care at home. Liv has a discharge date set of the 30th of July. She's now engaging with the ward psychologist and family therapist, both of who can work with the family through IOT as well. It's like a pathway. And she has a stable weight of 55 kilograms, which is absolutely fantastic. I just wanted to share a little bit of feedback. So feedback from our case manager from the provider collab is that one of the biggest strengths of the boroughs team is their ability to see patients as young people first and foremost. Throughout her admission, the team remained entirely committed to supporting her in her recovery. In spite of the very high risk to themselves, and the team's gentle and sensitive approach never changed. They remained compassionate and thoughtful, taking a dynamic and positive risk approach. I cannot think of another single team we work with alongside in the East Midlands who would permit a child to attend one of her hobbies or interests in the local area on the same day that a 10-person team is required to deliver an intervention. Such is the personalised, dynamic approach taken by the team. In their care of her, the physical and emotional toll on the team was high, yet they managed to hold on to hope for her future beyond hospital and showed incredible resilience. There is no doubt that every single person played their part in her recovery, but a special mention must go to the frontline nursing and healthcare support staff, led so effectively and compassionately by Sinead as ward matron. Her visible presence on the ward and reciprocal respect between her team makes the difference every day. And from Liv's mum, to have such a brilliant, caring, compassionate team around her, celebrating every little win like I do, means everything. I can't thank you all enough for what you've done for me and my daughter. When I thought my daughter was going into St Andrews, I thought I had lost her forever. I've had to relearn who my daughter is and how to be her mum. Just to summarise, the boroughs put Liv and her family at the centre of all decision making from the outset of her admission. They've gone above and beyond to ensure she has the chance to thrive outside of hospital. Thank you for listening to Liv's story. Her journey through our services is far from over. Life outside of hospital after 18 months won't be easy, but with the support of the teams around her and her family, she has the chance to be a teenager again and focus on the future. I'm going to hand you over to Simon and stop sharing.
Thank you, Marie. A really good summary in what's been an incredibly challenging yet rewarding situation and positive outcome for this young person. I mean, from the outset, it was a true collaborative effort to help and support this young person from prior to admission, working very closely with the collaborative case manager and during their stay on the ward. I mean, it's worth noting the team NHFT pulled together, even had a policy change as Marie referenced there. So recognising it was such a complex and almost unique situation and learning from it. And one thing to draw out of, during the admission, the ward manager reached out to the wider collaborative clinicians and leaders, and we held a session to share experience and learning and what could be the best way forward for this young person, because it was such a unique situation. The senior clinicians from leaders from the collaborative attended and were involved in those discussions. And I think just to finalise, the support of the CAMS 3.5 service, the intensive outreach team that's commissioned by the collaborative, has been critical really in ensuring that the home leave and discharge will be smooth, and the leadership on the ward really just needs to be recognised, and that's been fantastic in helping supporting this young person and the team involved in their care. So just pause there, Christian, and certainly invite any questions or comments from anybody.
Oh, thank you, Simon and Ray. What a story to describe, and hugely distressing in parts, one has to say, but also incredibly positive in terms of where we got to. So I think very thought-provoking, and I can see lots of hands and comments of people wanting to make comments and ask questions. So we'll take those, Marie and Simon. Thank you so much. Yeah, loop back round to you at the end. So first and foremost, Angela, please.
Yeah, thanks, Maria, and thanks, Simon. It's wow, what a story in terms of outcomes. You can't help but be impacted by it. I think it's great that you also felt supported across the whole organisation, Maureen. I think that really came across extremely well, and that's something that we should celebrate, but also understand how that works in other areas as well, because that obviously made a difference to it. And obviously stayed in great contact with you, and that was clear. And she was able to keep us connected as an executive team into that, which was really helpful in terms of the challenges that you're presenting. And I think Sachin, equally as the clinical director in there, has been sort of pivotal in this, and we've certainly had that conversation. But I popped down to the ward to once I knew, because I remember Anne sharing it with me in terms of the news of the outcome, and it was a Friday, wasn't it? And I popped down on the Monday to the ward to just to go in and say actually how fantastic they were, how proud we were of them as a team, and also to get a sense of what they thought had made that difference. And just in that sort of informal drop-in conversation, it was really clear that they'd felt very supported between themselves, which was fantastic. That, you know, there was no sort of division. There was a variety of people I was talking to. The person-centered bit was just amazing, and that had never drifted, even though it had been tough, and they described the tough elements of it. And they had a belief, which I think was really important. And I said to them, it'd be really good to capture this as a case study and learning, because I think we could share that expertise. It's great to share in East Midlands, but I think it could be more widely shared nationally as well. But no, they hadn't quite sunk into them what they'd achieved and how they'd done it. But I think we wanted to sort of play back to them that they had been absolutely phenomenal, and working together in an MDT way really came across very strongly. So I couldn't have been prouder of them, and I know the team felt the same. Thank you.
Thanks, Angela. Okay, Julia.
Thanks, Krishni. Oh, Marie, what a story. How impactful was that? And I think most of us are probably still digesting. I've been to the boroughs and heard similar cases, but certainly not quite to that extent. That's phenomenal. A couple of things just to bring out. One is that we see through a lot of our committees, a lot of the information and data around some sort of cases where this happens, you know, incident data and staffing data, etc. But you've brought it to life for us. And I think what you've reminded us about is the importance of understanding those stories behind the data, because you absolutely put that young person first. And the fact you changed policies and the fact that you responded so positively, I think that could filter through in some of the reports we receive, because I think that's the richness of it. We're still delivering quality care despite all these challenges. And thank you for bringing in all those other teams. I know that Joe, one of the other Neds, and I did a visit with Anne to the Preventing and Management of Violence and Aggression, the PVMA team. And that was incredible. Tiny team making such a difference. And the fact you brought in the moving and handling, you know, folk and the community teams, I mean, that's really, really important. And I applaud you, and please thank the teams involved from us too, because the effort and the commitment on a personal level, I'm sure, must have been absolutely phenomenal. So thank you.
Thank you. Thanks, Julia, for those reflections. And just actually, some of those thoughts crossed my mind. I remembered colleagues had been to see the PMVA team, so it was sort of really good to see them. And I've always known that they've been very proactive. They're not just a team that do training, they absolutely support people in live situations. But I was thinking exactly the same thing, Julia, about the self-harm data. So, you know, of course, when we look at our incident reports, we look at things like self-harm data, and we hear that the sort of the types of situations that might you know, prompt an increase in the levels that are reported, and this really just sort of I think helped us to perhaps understand that all a lot better, as you've rightly highlighted. Saqib.
Yeah, thank you for the story. Very, very powerful. As a dad to a 13-year-old daughter as well, I can empathise to a degree what it must have been like for the parents, etc. Just a kind of a clinical question, and in terms of a pathway, had we not had our partnership with St Andrews historically in the past, would that have still been the pathway? And the second one, having had my gut rested after appendicitis when I was 24, I can't remember what it's called. Is it TP or something, where you have a line actually into your neck and you're kind of fed directly? Would that not have because of the kind of the aggression, etc. Was the restraint feeding the only way that was possible?
Do you want to? So I think there were two things there. One was about the approach to feeding, and the other was, I think, Sakib, just about the sort of role of the collaborative and whether, being part of the collaborative meant St Andrews was more accessible. But I guess you would have referred to St Andrews anyway, whether they were part of the
Yeah.
collaborative or not. But I'll let you respond, Marie or
Yes,
Simon.
so St Andrews is our low secure provider in the collaborative, and we're just fortunate in Northamptonshire that it's on our doorstep. So obviously all of the other providers in the collaborative can also refer in, and that, I suppose, for us locally, that's a much better option because the young person stays closer to home. But the reason that we took Liv in the first place was because we really didn't want her to go into low secure. She was 12 on referral. Often the outcome for young people to go into low secure at such a young age means that they're in for a very, very extended time. She'd already had more than 6 months in inpatients. We kind of knew that may mean then that she spends her teenage years in and out of an inpatient setting or in a 3-year admission. Often they end up kind of in a long-term segregation kind of outcome because the outcomes are just very, very poor for such a young child to go into low secure, but that is our referral pathway, and we were trying to avoid that really, and it was kind of fortunate that there was a delay to that admission because it did give her that extra bit of time to kind of, we're discharging her, which we never believed possible from the boroughs. In terms of feeding, that's really, really tricky. So if a young person got to the point where obviously they were hospitalized and they needed that level of feeding intervention, that's what would be done. Often the young person is fit to come into CAMHS inpatient, so you've got very limited option in terms of how you would then feed if they're resistant to feeding. And we've worked, the PMVA team have accessed training that they then share with us. And this is probably the safest way to feed a young person. We use a safety pod, we use kind of an upright position. We use a certain number of staff to keep the young person in quite a robust position so that there's no risk of aspiration. But that's the safest way at the moment. I mean, this is all relatively new. It's kind of really became more difficult during COVID and post-COVID, and we've seen lots of younger children presenting with real difficulties around eating.
Thank you.
Thank you, Marie. Okay, Itai, please.
Yeah, I had a comment to make, but I'll probably just kind of jump in on the sort of question that Sakib raised regarding the feeding. I think having a parenteral feeding, which is continuously located on your neck, can be quite risky, especially when the individual is not consenting, so. The NG tube feeding becomes a much safer option in the sense that you only have episodes where you need to have them under a degree of restraint whilst you are administering the feeds, and then after that's done, sort of all external tubes and implements get taken away, and that minimizes the risk of someone using those things to self-harm with. So I think, my knowledge of this young person was that I think they were a lot more disturbed at the time of feeding, and during other times when they were not being sort of made to feed against their will, they were quite amenable, quite social. So I think the options that were used by the clinical team at the time were wholly appropriate. I just wanted to sort of highlight, the strength of, the collaborative in this. So it just so happens, I think, fortunately for us, that's the consultant of the patient, just happened to be the clinical lead of the provider collaborative, who also happens to have a very strong network within the region. But all that being said, was very, very humble, very, very open to, suggestion, would seek advice. He would often talk to me about, that we've got the situation, it's very tricky. I've got concerns about, the nature of the restraint. Can we have some kind of, external oversight regarding this? It's so open with the clinical team that, we ended up actually asking, other partner organizations in the collaborative, who had experience in, restraint to, review the case, advise us on whether what we were doing was appropriate. And I think that's important in the sense that, we were not, being sort of closed in our approach to, management and treatment of, a quite difficult patient. But I think that whole element of, risk sharing across the collaborative, sharing of, clinical expertise, I think all of those elements are kind of drawn out by this case. And I think it's interesting that we sort of talk about the difference between, an ordinary CAMS bed, a PQ bed, and a low secure bed. And what's becoming more and more apparent for us, within the collaborative is that, we need to sort of start having those kind of tailored packages of care, and not be too fixated on, where those, patients actually are. So if you look at this case, you could easily argue that, well, this person should have been in a PQ, and the Burrows is not a PQ. But I think, the level of resources needed to sort of manage the patient safely were mobilized. Many thanks to Paul, as commissioner, for actually, making those resources available to have that kind of, creative approach to management of a patient. And I think it's, increasingly becoming an approach that we want to sort of use across the collaborative. And we'll be meeting as medical directors and directors of nursing to kind of look at how we can sort of approach things in a more creative way, so that, we're not sending young people out of area, and we're equipping, other units, to be more responsive to, increasing risk and clinical needs. I'll stop there.
Great, thank you, Itai. Really helpful, I think, to understand all of that. Robin, please.
Hi, Marie. We were aware of this case, certainly at Quality and Safety Committee, because we saw all the data. We could see that we were hearing reports of an individual who was consuming so much staff time and creating so much challenge to the ward. So we were aware of it, but it's really, really helpful as a board to see that described in detail, particularly with the positive outcome that we've heard today. And my comments simply towards the team, towards the team itself on the ward, and the quality of their work, the quality of their commitment, the quality of their energy to try and bring a good outcome for these young people. And as a board, I think we need to say thank you to them.
Absolutely. Thank you, Robin. Linda.
Thank you, Chair. Thank you, Marie, for presenting that case, which I'm very aware. I just wanted to come in on the aspect of restricting to feed, just to provide some further assurance. So whilst we had this young person on the unit, and it was really quite a difficult time because I went around there several times, just like Itai and other colleagues, we stood up a number of clinical senate meetings where we're very senior clinicians in the organization. So arriving at what was the safest option went through quite a rigorous process, including having our colleagues in knowledge services pull out information on best practice guidance. So we looked at NICE guidance, we looked at other recommendations, and hence the reach out to other areas to say, are we doing this quite right? We looked at the implications of the restricted practice, and hence the input of dietitians and other colleagues working to have that feed time then just once a day as opposed to several times a day. What was useful for the team was the wraparound support and debrief to the staff who were involved in that, because it was quite difficult. And as Marie said, it does impact that therapeutic relationship. So although we had staff who had sustained injury during that time, most of the staff, whilst they were, as soon as they were fit, they wanted to come back into work. So they were not asking to be moved to other areas, even though it was offered. So clearly there is a really good culture and ethos in that particular service, with all the team wanting really positive outcomes for this young person. So we went through quite a lot of stuff. MDT was absolutely central in leading that, working with the family as well and the young person, but certainly in the background, as senior colleagues, we were going through the process, ensuring that it's safe. And actually at each point, we were stopping to sort of get updates. And I know Sachin was, a number of times he was saying, can we discuss this again? Can we look at this again? Which we absolutely welcome. So thank you to the team that was involved.
Thank you, Linda. Thank you very much. I mean, this is sort of MDT working multiplied n times, isn't it? And I think you've in what you've described, you've talked about bringing in best practice, external scrutiny, and I mean, there's so many elements to this story which are incredibly powerful, and most importantly, that sense of absolute outstanding compassionate care, which ultimately is what we're aspiring to. I also just wanted to mention that I happened to be actually coincidentally at a meeting, just a regular monthly meeting with the regional team as chairs that we get invited to. And interestingly, one of the Giles Tinsley, who I think is a regional mental health lead, happened to mention CAMS and CAMS Tier 4 and the work that was being done by collaboratives, and particularly highlighted the work in Northamptonshire. So I just really wanted to mention that because Giles was really clear that, and I think, although he didn't go into detail, my sense was he was talking about what we call CAMS 3.5 or Tier 3.5, I think, Simon, you said, which is the intensive outreach team. Because certainly as a layperson, I think I always remember, I mean, for those of us who've been around a little while, will know Sachin pretty well. And I do remember Sachin saying very clearly that being particularly for children and young people, being in an inpatient setting is not always a positive therapeutic setting for individuals. Sometimes behaviour can be learned that is not helpful when you're in an inpatient setting. So that sort of drive to, I think, intensive outreach seemed like a huge step. Yeah, it's really, really powerful story. As I said at the beginning, very at points distressing. It did pluck a few tears at the end when in my eye I was thinking, goodness me, what a journey to have been through. But I think really importantly, fantastic outcome for the individual. But thank you so much to the staff who've clearly, really gone above and beyond in supporting this young person, and no doubt other young people. And this is one story. So, and I'd be very grateful if you can pass that back on behalf of the board and Marie and Simon as well. Anything else that you want to add before we close, Marie or Simon, or Anne for that matter? Marie?
No, thank you very much for having us.
Great. Simon, anything else?
No, thank you, Krishna.
Okay, Anne, do you want to add anything?
Yeah, I'm just incredibly proud and in awe of the work that's happened in just seeing that determination and hope that they've held. Fantastic. And as Linda said, the multidisciplinary work, amazing. So we'll get the messages back to the team. So I think it's really important they hear that feedback. So thank you.
Thank you very much. Thank you. Good to see you again, Simon and Marie. And thank you so much for joining us. Okay, well, that's set a very, I think, important context for us and for the rest of the meeting, as ever with our patient stories. And it does strike me that one of the things we might want to do with our governors is think about whether there's a story that we would want to share with them, not necessarily this particular patient story, but that sense of some of the work that we're doing as a collaborative and what the East Midlands Alliance is doing, because I think it does bring to life a whole set of different things that governors might find helpful to understand. So perhaps that's something we can think about in terms of providing some insight to governors as an assurance topic. Okay, moving on then, Richard, over to you on our risk section, please. Oh, actually, no. Yes, sorry, paper D, risk report, board assurance forever. Over to you, Richard.
Thanks very much, Christian. Good morning, everybody. So yes, paper D in the pack is this month's risk report. It's the first time actually the board has received the full information on the assessment of all of the risks within our new BAF. So not only the current target and risk scores, the progress being made against these, but also information concerning controls, assurances, gaps and actions. As you might imagine, as the first iteration of this style of report, we should expect the format and indeed the content to mature over the coming months, but nonetheless a positive milestone, I think, in our development journey with our BAF. So it's probably also worth pointing out that although this is the first time that this full suite of information has appeared in the board, the elements that relate to individual committees are being routinely reviewed and have been for quite some time. So turning to the actual risk scores themselves, the board will note that the overall level of risk in this month's report remains largely static. We have moderated down the risk concerning the objectives around staff wellbeing, which is BAF 3, and that follows the reappraisal of our position within the wider health economy. We will also note that we are planning at our August workshop to review the risk appetite statement. We deferred the annual review until we'd received the strategic objectives for this year, so we should expect to report back to the board formally in September with the outcomes of that and a refreshed risk appetite statement. And the last thing I wanted to draw out the report in response to some conversations I've had with NED colleagues is related to the work that we're doing on operational risk management. We're at the moment working with operational leads and indeed with EMB to strengthen the escalation and de-escalation of operational risks. And we can start to see in the BAF report this time some of the links that we've then established between those strategic risks and the underpinning operational risks. But as this work progresses, we will then start to see this information much more robustly presented in the BAF reports and indeed referenced in the committee conversations on relevant papers. So I think with that, and in the interest of time, Christian, I'll hand back to you for any questions. Thank you.
Thank you very much, Richard. So just invite any questions or comments from colleagues. So Judith, please.
Thanks very much, Richard, for the update. I mean, as ever, very, very supportive of the development of the BAF and all the risks associated. Just a couple of, a question and perhaps an observation. Totally welcome the work that you and the team are currently doing with regards to escalation of risks. This is something that you and I have talked about. But I was just wondering if you have an expectation of a timing around that, because the linked risks are quite important. And it is, in fact, something that's come out of our well-led review as well. So it'd be good to understand, if not today, but sometime in the near future, as to what your timing expectation is on that, on delivering that. And secondly, I really welcome that, that, as I said, the change from the risk register to the BAF. And you have also started doing work on how our BAF, if you like, can link or links with the BAF at ICB level. But I was just wondering how we can sort of, if you like, elevate that so it becomes clear how ICB risk potentially impacts on our BAF. Because right now, reading the wealth of information we have in our BAF, that doesn't come out at me.
Thank you very much, Judith. Do you want to, and apologies, I meant to say I'd agreed with you that she was going to stay off camera today, but she's very much present, as you can hear. So just wanted colleagues to be aware of that. Richard, did you want, should we take Joanne's question as well and then bring you in to comment? Joe?
Yes, thank you, Richard. Just a point of clarification. In the covering report, you refer to the necessity for training, and you're linking it with activity in the transformation programme. Could you just confirm that it's not a one-off piece of activity? It's actually going to be embedded as part of our mandatory training and induction packages, please.
Thanks, Joe. Shall I start with that one and then go back to the two questions from Judith? So yes, absolutely. We've refreshed our training programme in light of the creation of the BAF and the creation of the corporate risk register. So we've always trained staff on risk assessment and using the risk register at a local level. So what I've referenced here is the sort of refreshed training following the introduction of some new capabilities. And yes, that would then be normalised going forward. So yes, all staff would routinely receive training into the future. The point about timeframes, it sort of links with that comment there actually. So we've set a time frame of the end of the calendar year to complete a large amount of the training on this new approach. So we'd expect to then see the improvements in operational risk management working coterminously with that as staff are trained on the new approach. We'd expect then to see the information flowing through accordingly. So we should see stepwise improvements as we progress through the year towards that December completion time frame. So I think that's hopefully a response on the time frames, but we can certainly have some further conversation outside the meeting on some of the detail if required. What about ICB risks? Yes, that is very much work in progress. I think it's certainly very important that we are working collectively as partners on understanding our own individual risks, the system risks, and the interplay between them. So I'm working very closely with the system governance group on the work that's being led at system level on the refresh of the BAF. And we will then need to give some thought to how we have a communication between trust and system to make sure that's really, really optimized. So we are learning from other systems. We've linked in with a couple of other ICBs to see how this works elsewhere. But yeah, I think you're right. You did point to that as an area of further development for us. So we can hopefully come back with some further information as that work progresses at the next meeting.
Super, thank you, Richard.
And Richard, just on the operational risks, sorry, did you pick that up as well? That I was sort of, yes, you did. And I was going to say actually, because actually in respect of BAF, apologies, I'm just trying to see in BAF 4, which was all about our workforce resourcing to some degree when I was looking at that. And by the way, just to say this is great work. So before I make any comment, this is great work and really good to see the development of this. It was probably a little bit surprising to see that there was only one linked operational risk around resourcing. And and it may be that is fair and correct, but given some of the challenges around recruitment to particular services and safer staffing, I did wonder whether there might be some more operational risks around resourcing that we might want to highlight there. So it was reinforcing to some degree what I think Judith was saying about the evidence of that linkage really, and kind of developing that a bit further, because I think the structure of that is really good, because it really does link the sort of corporate risks to things that we're considering strategically. Joe, did you want to come back in?
I did, yes. It was just to push a little harder on the theme that you did opened up, Richard, if I might, because obviously BAF 1 isn't just about system risks from a Northamptonshire perspective. Our partnership agenda takes us much wider than just the Northamptonshire network. So it would just be good at some point, as this document matures, to hear the voice of our other partners which are outside of our specific geography, because I think in order to get that BAF 1 fully rounded, we should look beyond our immediate geography. Thank you.
Thanks, Joe. Just briefly on that, I know Angela wants to come in, but certainly just to confirm, we are indeed working not only with the ICB, but also with our colleagues in the East Midlands Alliance, actually, on risk in regional collaboratives. So I think you're totally right. We're not just looking at local partners, and indeed through the Collaborative Commissioning Committee, that's where we would then bring in some of those more regional risks into the conversation. But yeah, thanks for pointing that out. And you're absolutely right, Krishni. The current presentation of operational risks within the BAF isn't a complete picture just as yet. So we would certainly have more resourcing risks to play. So that will start to mature, as I say, as the training goes out, and we see future iterations of this report.
Great, thank you, Richard. Angela.
Yeah, thank you. And again, I would echo the positivity, how this is developing. It really is helping. And I think, as Richard said, more to come. Just in terms of the ICB, I think important to say that that's still maturing. So again, that's still work in progress, I think, from an ICB board point of view. So again, it's helpful that Richard is staying close to that, as well as myself on the board. But the other point that we probably just need to tease out with the ICB a little bit more, Richard, is the fact where we play a lead provider role in our collaboratives. Where does that start to play, and understand that relationship? Because that will be something we probably want to explore here. But no, helpful. Thank you.
Okay, so I think, Richard, at this stage, you obviously, this was for our consideration and review, and people have commented on areas of work that are clearly ongoing, and people would like sort of assurance, really, I think, was on the development of the operational risks and the links to the ICB, which were the things that came up. But that is an ongoing process now that we're going to see play out, I think. So, and really good to hear about the training as well. So thank you, Richard, for this. And this will now be a regular feature. Well, it's always been a regular feature, but we will see this coming back to us, and obviously we will see its development in the course of the year. So thank you. Okay, Anne, over to you on any aspects of winter planning system-wide that you'd like to comment on at this stage.
Yes, thank you, Krishni. Just to update the board, we're still seeing a lot of challenge outside of winter, which is bearing out nationally, really, on pressure on A&Es and ambulances. So we are very focused on what's coming ahead in when we do get into real winter. We had a summit for the system for the executives 2 weeks ago, or nearly 2 weeks ago, where we just pulled together things that we were doing, things that we needed to maybe look at with more focus, and where ideas for any future ideas for winter were coming. The COOS meeting have pulled that together into a set of, there was a certain amount of things that were shared that would require financial input, and we needed to review that and think, and to be able to present that back to the system. It's increasingly looking like there is no winter funding necessarily coming through, but actually what do we as a system want to do about those needs? There was also things that we could pick up before we got into the heart of winter around process, and some auditing, reviewing patient stories to think about how we might do the things that we do slightly differently, which was sort of a cost neutral approach. And then there was a longer term set of objectives around how we work with certain pathways. For example, some of the work around dementia and delirium, but other pathways that we have, and what we would do as a sort of strategic view as a system. So that work is being pulled together to be presented back to the system execs, and that we should have a plan in place, or an enhanced plan in place. We have had a plan, but it's that and enhancing that all the time to get the optimum out of everything we've got as we move into winter. So that should be for the end of August, beginning of September.
Thank you, Anne. Helpful update. Any questions for Anne? Okay, thank you. Finally, in this section, we have Paper E, which is the AAA report from the Integrated Assurance Committee. I should have said, I think Tim is an apology for this meeting. I'm aware that he's actually on holiday at the moment. So, Judith, is there anything you'd like? I know you. Would you like to come in on as deputy?
I think the short answer is no. I think the report is very much clear on what was discussed. We didn't, from a risk point of view, we didn't have anything additional to discuss that we normally do. However, with the celebrate outstanding point, I think is definitely something that I do want to mention, which was with regards to Meadowbank Ward and the response that the staff there gave to a pattern of safety incidents that were occurring after hours, if you like. So that was a discussion that we had at the committee. But apart from that, it was there was nothing else that I wanted to highlight. Thank you.
Thank you, Judith. Apologies if I put you a little bit on the spot there, but I hadn't considered that at the moment when I was thinking about who to bring in. Okay, so any questions or comments? I mean, I think it's really helpful to highlight that outstanding practice. There's some references clearly on the risk report and the BAF. I think we're going to probably pick up on I was certainly going to comment on possibly the link between the employee relations cases and kind of increased likelihood of ethnic and cultural minority colleagues entering the disciplinary process and concerns about a recent report relating to the NMC. But I think I'll let Angela just comment on that first, and then we can perhaps pick that up. But any other questions or comments on that report from colleagues who participated in that committee or anybody who wasn't present? Okay, so thank you. We'll note that and thank you for the report. Moving on then to the strategy section, an environmental analysis item first. So Angela, I'll bring you in to share with us anything you'd like to at this stage.
Yes, thanks, Krishni. So just a few things to highlight. You just mentioned the NMC independent review of its culture, and I think important just to highlight to the board that that is now published. This was a report that was commissioned by the NMC itself, but clearly it has resulted in a range of findings that are quite concerning, well, very concerning actually, and upsetting. And there is clearly a lot of work to be done. I think it, in summation, talks about the fact that voices weren't heard, discrimination, racism, bullying and harassment, a range of things that would cause concern for anyone. So they have apologised, they've accepted the recommendations in full, but I think important to say that obviously, as chief nurse, Linda remains very close to that in terms of, you know, how people are feeling about that across the country, but also locally. We did send a message out to our staff immediately, and in actual fact, NHS England asked me for that message yesterday so they could share that more widely with others and suggest that they also reach out to their staff at this time. But a very concerning read, and one in which we will keep very focused on. And as I say, we can come back to that, and I'm sure we will as an organisation. Other bits that I wanted to highlight in the environmental analysis was that we've now got a new chair across UHN and UHL, Andrew Moore. And again, that's I know known to some, but I think really important that Andrew did come along to our integrated care board recently to share his thoughts, which was very helpful and very welcomed. We also had and hosted a non-exec director session across the ICB at Berrywood Hospital recently, and we focused on social value, which I think was a very useful session and a way to not only obviously strengthen our relationships across the integrated care board, but to also focus on the work that we're doing and can collectively do in the integrated care board space. And then I just would finally highlight that at a recent integrated care board, Anne, myself and Morgan had the opportunity to update the board on the mental health, learning disability and autism collaborative work and to understand and reflect on its journey. That was really well received and a really good, I think, summary of the work that's being done across the partnership. And I think a couple of comments that we received during that from one of our primary care colleagues was, it's a delight to be involved in. And the chair of the ICB said that it was integrated care in action. And I think that's really important in terms of just sharing with the board that that is the comments received. And I'll leave it there. Thanks, Krishni.
Thank you very much, Angela. And really, my reference to the NMC report and the link to the integrated assurance report was really, I think we've seen a common theme of our ethnic and cultural, collectively within the NHS, ethnic and cultural minority staff being disproportionately referred into disciplinary processes, into professional. I think there was evidence in the NMC report around also sort of disproportionate professional regulator referrals. GMC have referenced that in the past as well. So it is just something that we've just got to be constantly looking at collectively, I think, within the NHS, but obviously remains a focus.
I mean, Chris may be coming on this, but I think it's important to just share with the board that we do have a decision panel that meets ahead of those processes, which is important, and clearly seeks to make sure that staff are treated fairly. And that's external to the services, and that's led by Linda and HR colleagues.
Yeah, thank you, Angela. I know we've done a huge amount of work on this, and so it's really, and obviously has been subject of discussion within our sort of res reports, and we've Chris has talked us through all the work that's been done in the past. It's just concerning, I think, that this kind of professional regulator referral point remains a wider issue within the NHS, rather than as a specific issue for us alone. It certainly isn't that. So, Chris, do you want to come in on that?
Yeah, Krishni, thank you. So I think Angela's referenced the decision-making group, which you may recall we had a period where we had very high referrals of, I think you remember we talked with you, of ECM colleagues. So the decision-making group's been a key part of bringing that down. It has slightly risen in the last set of reports. It's a complicated process, but the HR team, I think we're talking with Linda and Anne as well. So we are looking to review that process and how we make it work. I think we assure the board that we are continually reviewing the work we do on it, because it is important, and the complexity of investigations undoubtedly has gone up as well. So the environment in which we're trying to work, we should be aware it's increasing, and so we have got work on that. Equally, I think the time investigations are taking is an issue, and we've talked about that, and the team are working with Paul to see if we can put some more resource into that, which ultimately, we are facing real financial challenges, but actually improving those processes probably will have a financial knock on an improvement if we can invest in it. So we've got to work that through with Paul and see how it can be done. But I think it's assuring that we are actively looking at all of these elements, because the commitment is there to improve all of these processes.
Yeah, absolutely. Thank you, Chris. Linda?
Thank you very much, Krishni. Just wanting to add on the point that Chris has raised. So through decision-making group, we've had more cases presented. I just want to highlight that it's not an increase in professional nurses as well as nursing associates. This is for the wider trust. So whilst it might look like we have more cases coming through that process, but actually it's trust-wide, and we welcome that, because actually we can see what's going on across the organization. I maintain the database of all NMC and healthcare professionals, which is our AHP's database for anyone who's referred, including the updates on what's happening with those individuals. Some people might have left the organization. As long as we were the ones who referred them, then we still get updates from the NMC. Unfortunately, we've got cases where people are referred by members of the public, so we end up not getting an outcome once that person has left the organization. And going through the figures that we have for nursing, we've more than reduced the numbers that were previously being referred. When we look at the number of ethnic minority, global majority colleagues that are being referred, that's sitting at the lowest that we've ever had within the trust. And certainly we're now starting to see those cases being screened faster than what was previously a very, very slow screening process. Some are attached to other issues, so they don't move as quickly, but certainly we've had quite a number where there's been no further action for those staff. We've got a process internally where any of our staff whom we refer, or have been referred by someone else, or they've self-referred, which is what the NMC also encourages, get support. So our professional nurse advocates, our PNAs, will provide restorative supervision. And certainly through my team, we then ensure that we've got a buddy system, a link to support that individual and signpost where there's need for their well-being. So I'm happy to include information on this for our next report in the workforce safeguards that will go to the Integrated Assurance Committee so that they can actually see more of that information and be assured if that's really helpful to the board.
Thank you, Linda. I mean, I think that what you've just described is really helpful to just have shine a little bit more light on this. As Chris has rightly highlighted, this is, has been I think an ongoing area of focus for us, and we have massively improved in many areas. And it's really good to hear, I think, Linda, about the support, because I think that's the other area, isn't it? People unfortunately do get referred or do go through difficult processes, but it's how we support them as well during that. So very helpful to hear all of that, and thank you very much. And if you're able to include that additional information in your report to IAC, I'm sure that would be welcome. So thank you. Okay, so we move on. We know Angela's update. We'll come back to Angela's Chief Exec's report in a moment, but just on my chair's report to the board, which is paper F. First of all, I just wanted to highlight that I think the first of our Governor and Ned constituency meetings took place maybe last week. If Robin or Joe would like to comment on that, most welcome to do that. I think we've got another one scheduled for next week, and I'm kind of quite excited to hear how these go, because I think we found that they'd worked really well previously last year when we tried them, and obviously with the new group of governors, it'd be very welcome to see how this works. Robin, did you want to come in on last week's meeting?
Just to report, as you asked me to, it was a really positive meeting. We had a presentation from the head of Young People's Services, who gave a really comprehensive overview of all the different services that are available, and it elicited a brilliant debate between and with governors. They're an extremely informed group, and they ask superlative questions, and the quality of the dialogue and the discussion was really exceptional. So I think it was a good example of the way we need to work with our governors. Perhaps Joe who was also there, may share my view. We certainly share that view between ourselves after the meeting. So it was excellent.
Thank you, Robin. Really helpful to hear the feedback directly from your attendance and involvement. Joe, anything you want to add to that?
Merely just to add, Krishni, that I think it actually opens up some thoughts for us about how we better engage with governors on some of these real life issues, because as Robin said, there was lots of lived experience in the room, and certainly it opens up a channel of communication which allows the voice of community to be heard in our meetings, which was invaluable.
Yeah, brilliant. Thank you, Joe. So really good to hear that, and let's hope that the meeting next week goes equally well. Also to highlight, important for the board to note the scheduling of our annual public members meeting, stroke annual general meeting of the Council of Governors. That's scheduled for the 23rd of September at 5:30. And obviously we would encourage as many members of the board and as our Council of Governors to attend. It's an important opportunity for us to formally share our annual report and accounts, but actually importantly to showcase what the Trust has achieved and look forward to kind of other things that might be coming along. And I know Judith is involved in the planning group, which has members of as governors, and obviously Richard's team involved as well. And hopefully it will be a really great showcase, which has been with governor input over the last couple of years, and obviously important opportunity as well for members of the public and members of staff to ask us questions as well. So, and I think Judith has just added that it was a very positive meeting. So I know that first meeting took place, I think, last week. And finally, just to mention really that we had a fantastic, I think we have touched on this informally in one of our board development workshops, but there was a fantastic reception for colleagues with long service, which was really fabulous. And thank you to the comms team who helped us to put that together. Also to mention that a number of us, as Ned certainly, and I know execs as well, attended a team talk, no, trust talk, I think we called it last week. That was amazing. I think we had over 400 people join that. So it was like a sort of team brief. It was online, and I think it's going to happen regularly, isn't it, Angela? So that was lovely. Really enjoyed that. And I also want to just highlight the service visits that colleagues have been on. I think there have been a number to prisons, and there's been some really positive kind of insights from that, as well as obviously opportunities for us to respond to things that might have come up. So if there are any other things that Neds would like to share from their activities, I can happy to take that, because I think it's something we should encourage you to share in these meetings. So does anyone want to add anything else before I hand over to Angela? No? Okay, Julia?
I suppose it's just a plea out publicly, really, to all our staff, because we are out and about quite a bit and we do have some really useful contact. But certainly one of your bullet points on there, I attended a preceptorship programme which had lots of different multidisciplinary professionals on a year-long programme talking about the role of the board and the role of non-execs. And they asked me about my personal journey, for example. But actually, though, that came from a very informal contact. And I suppose it's thinking about an open out to all our teams, lots of any different opportunities people have that want to understand the role of the board a little bit more, and and our role as Neds would be really welcome. So any opportunities, do let us know, because we take them, and the contact is incredible, and getting to meet so many new staff is really valuable. So thank you.
Great. Thank you, Julia. Really the most important thing is for the board to note the date of the Trust APMM and AGM, and obviously maximise attendance at that event. So thank you, and I'll hand over to Angela for her report.
Thank you, Krishni. And I can start by thanking all of our staff and volunteers for the work they do. I think we've heard a story this morning, but there's so many stories that it's just important just to thank them for what they're doing every single day. So I assume the paper is read, but just a few things I wanted to highlight. Since writing the paper, we've obviously had the election, and we've had a change in MPs in the county. So again, just signalling that, and that Toby Sanders, the ICB CEO, and Richard Mitchell, the UHN CEO, we did a joint letter reaching out to all of them to introduce ourselves and encourage them to work with us in relation to the work in the county. So hopeful that will happen, and already we've got one meeting set up with one of them. So that's encouraging. Just highlight in the report that the West Northamptonshire SEND report is now published. Similar findings to Northants in terms of more work to do across the partnership, and I think commissioners in the council and the ICB have recognised and accepted the findings, and we will continue to work in partnership with our colleagues to support those improved outcomes for children and young people. Really pleased and encouraged to see the innovative befriending scheme. So again, I think that's a great example of creativity and also helping and assisting, even though it's challenging times. So I think I love that. I think it's been a fantastic example. Krishna, you've mentioned the trust talk. I think, again, I would just say thank you to our comms teams who have taken us into that new approach around connecting across the organisation. As you say, the first one, very encouraging, a lot of positive feedback. And hopefully that will continue. And for those that couldn't join, obviously the recording of it is still available. So that's important as well, to keep the connections live. At the same time, you know, Itai and colleagues are also still championing the Dragon's Den, our innovation space, and it continues to attract a lot of energy and a real sense of optimism to do things differently and to understand how we can do that. And that's really encouraging. We were able to share that with the CQC recently, and they were very encouraged by that, to understand it in challenging times, we're still rising to do things in different ways. And then I just wanted to highlight some forthcoming events that are coming up that I think is important just to make sure the board is aware. So on the 18th of September, we've got our Compassion Conference, which is one of a series of events that we've had to celebrate and actually connect around compassion across the organisation. We've got our Allied Health Professions Conference in October, the 14th, I think it is actually, and obviously Linda has the details for that, but I would encourage people to come along to that. And we've got a Research and Innovation Conference as well on the 24th of October. So looking forward to a range of events coming up to really sort of start to galvanise across the organisation in these areas too. Thanks, Krishna.
Thank you, Angela. Any questions or comments around Angela's report? Okay, I think it's just for our noting, but I particularly was taken by the befriending service. It was really good to see something that had been developed for, I think, a different purpose initially, or the yeah, but to take it into that space felt like a really positive thing. I know Joe, I think, and others have commented in the past about sort of waiting well, and I think this is a really good way of sort of supporting people whilst they're waiting. So I was very taken by that, and important learning to be shared around other you know, about broader issue about support for people whilst they're waiting for services, which is a general, I think, concern. So really positive, thank you. So we note that update and we move on to paper H. Now, as we've said, unfortunately, David was on a planned leave from today, and Alison has been unable to attend. So I think we'll just go straight over to any comments or questions, and if it's okay with colleagues around the room, we'll just, if there are specific questions about sections of the report, we can perhaps just ask the lead director for that section to respond. So anything that colleagues would like to comment on or ask questions about? Julia, please.
Just to comment first to say, really well structured report, very easy to read, very easy to see what our priorities are and our progress against them. So that's great. Thank you. Really, really minor point. On the front page, it talks about the last bullet point, grow should actually be quality. So it talks about assurance through our subcommittees, which several of us, the NEDs, chair the committee, so we absolutely are familiar and see this routinely. But it does talk about innovate and grow as the areas that are overseen by quality, and it should be innovate and quality. Minor point, but actually the overall theme is really enjoy the report, and it's good, clear overview of all our progress. Thanks.
Great, thank you. Joe, please.
Just a tiny sort of reflection in reading through this. The one comment I would have is it just is quite difficult where we have amber or even red ratings to get a sense of impact on the overall timescale and deliverability of the programme, Krishni, because obviously the assumption is that if something's slipping, it may have consequences beyond that. So just a question of how we try and capture that so the board can gain assurance on that.
Okay, thank you. Thank you, Joe. I think useful comment. And maybe, Richard, we could just feed that back to David, because I guess that's a broader point about the presentation of the report. So it's just risk to timescales, really, and maybe how we feed that into the report where there are some things that are amber. I don't think there is anything red as I could see it.
No, not this time. Yeah.
So yes, any risks to timescales in terms of delivery, and perhaps highlighting that more broadly in the covering report. But otherwise, I think we're just asked to note the progress and welcome, obviously, the developments that are reported, and the kind of quite a lot of elements that are actually clearly in progress as expected and reported as green. So thank you very much, and of course very clearly linked to the BAF, which was part of the development that we've been really working on and focused on. Moving on then, we are actually back on time. I was a little bit concerned that we might be running late, but I think we're okay. So it is probably a good opportunity to take a short break. Hey, welcome back, colleagues. So we need to kick off our meeting again. And we are now at item 11, which is the integrated performance section. So the first report is paper I, which is the Alert, Advise and Assure report from the Performance Committee. And Judith, I would like to welcome you to just cover anything you'd like to highlight, please.
Thank you very much, Krishni. I will take the AAA report as read. However, there are a couple of things I would like to highlight. First of all, the two items on the agenda that appear under the advise column are the financial performance for month 2, and we are in fact in month 3 now, so it's a little bit out of date, and the group value transformation programme. The reason why these two items appear under advise is clearly for our financial performance. We were running a small deficit on our deficit, if you like, of a small variance in month 2. And that therefore, this item does need to appear under advice. And in addition to that, our position then with regards to capital spend has not yet been finalised. It is now under month 3, but nevertheless, for month 2, the financial performance appears under advice. And similarly for the group value transformation programme, although some really excellent work is currently being done, where the aim is to deliver a saving of about 2 million, the actual reporting and identification of under the group umbrella where that transformations and money saving, if you like, will be recognised is something that the both directors of finance are still working on. So there is work to be done there, and therefore the item appears under advice. Under the assurance, we received a lot of rich assurance as ever under the from the integrated organisation report and the BAF, and a number of other reports that appear in the AAA report. However, the 3 things I do just want to highlight, because they don't appear very frequently on our agenda, is the PFI annual performance and life cycle report, which was very pertinent because there is national discussion around PFI and performance and how trusts need to deal with performance of PFI contracts. So it was very timely for us to be discussing that, and the committee received very good assurance around it. We also received an excellent report on our annual review of our joint ventures, which is always very welcome. And finally, the NHFT board awareness cybersecurity. I feel a little bit mean that I didn't suggest that this item appears under celebrating outstanding, because we had Chris Wells coming to the committee, who's a senior cybersecurity manager, and he talked to us around cybersecurity and all the work and the strategy that is going on within the trust to prevent cyber attacks and to reduce human error. And the presentation was excellent. So I apologise to Chris, who's not here, but I do think that should have come under celebrate outstanding, because we are in fact in a position within the trust, unlike perhaps some other organisations within or without the NHS, where we are in a good position with regards to managing our cybersecurity awareness and security. Apart from that, I don't want to highlight anything else. I'm very happy to take questions though.
Thank you very much, Judith. Really helpful, brought that to life. Any comments or questions for Judith? If others haven't got any, I was just going to actually mention cybersecurity because it's very pertinent, as we all recognise. So really good to hear that assurance that you've got colleagues got at the performance committee. And indeed, we've obviously, as a board, also not that long ago, jointly received some cybersecurity training. Just to highlight, I think there has been a regional request that has just come through probably in the last week or so, asking colleagues to attend a further regional workshop on cybersecurity. So I know that we were looking at who might be able to go to that. I think they were looking for one person from each board to attend. But good, clearly important to note that actually we got that very positive assurance within the performance committee, notwithstanding the understandable concerns given, I think, the recent. I know it wasn't a cybersecurity event per se, but the recent outage probably just reinforced those concerns that and affected obviously quite a lot of partners as well. So thank you, Judith. We note the report and particularly the areas that Judith has highlighted. So we move on then to the integrated organisational report. Obviously, this is a report that Dave would normally cover. It's got Anne against it first. So Anne, I'm coming to you. And no doubt you'll bring other colleagues in if you need to. So paper J, please, Anne.
Thank you, Krishni. So this is the month 3 report for end of June. And as you can see, or will see over time, there's continual update and improvement to it as part of a development programme. I'm just going to pick a few key points out that I think that is important to share, and then I'm just opening it up to my colleagues if there's anything that they would like to pull out before we go to questions. I think it's important, it starts off to say that referral rates continue to be extremely high into the organisation. That's a national picture, but it is the demand for services from our communities is ever increasing. With that in mind, our teams are working incredibly hard. They've heard of a number of different transformations in the committees that we attend. But waiting lists, although they're high, we're seeing 91.9% of people they're receiving treatment within the 18 weeks, and that was the position at the end of June. So we've maintained that position with the pressure on demand that we have. Outlined in the report is just the update on the 2 consultant-led services. I have to say they're completely almost at the opposite ends of the scale. So the specialist palliative care is performing extremely well, and that ranks nationally as well. But we continue to have concerns of work that we're working through with our community paediatrics performance. We received at Executive Management Board an update on the system review this week, so we're just sort of processing that. But I think it's fair to say the system's ready to take some steps forward in making some changes for our young people, which would be also in line with what we would expect from our sort of SEND action plan. So I think that will start to see a change for us as we get a sort of a system direction on it. In regard to workforce, recruitment and retention is an absolute core focus, which I'm sure Chris will touch on when he comes in. And that has to be the focus with our sort of dedication to reducing agency. Did you want to come in there, Chris, and just touch on that part?
Yeah, I mean, clearly that is a big focus, the recruitment and retention. I think positive that the vacancy rate's still under 10%, but trying to keep the staff level. Basically, the amount we've got level obviously will impact on a lot of our indicators. Positive turnovers come down slightly. We have got a lot of focus on turnover. We are looking at whether we should slightly change the criteria. I spoke with Nottingham and they don't include the doctors in rotation in the turnover figures, which we've looked at in the past. We are doing a deep dive on that. We've also mentioned in some of the committees a stability index, which will look at how long our staff have been in post with us, and we'll be bringing that through to the IAC to talk about what we're doing about that again on recruitment and retention. I think on the appraisal we are very close, but I think, Anne, that is something we have focused on in EMB and we need to come back to again, particularly for corporate. I think we can get there and we must do that, so that's another focus. Sickness still a challenge, but again we continue to focus. Our agency has come down again this last month. That's an area I think Anne would say, and Itai and Paul, this is an area of intense focus. I don't think that underplays it. We are looking really hard at the medical agency and recruitment, and all of us are engaged in this, trying to find ways to look at how we attract medics into the organisation, and I think that will bear some fruit. We're just finalising an approach and a strategy. Those are probably the highlights from the workforce element.
Thank you, Chris. We've also got in here, obviously, our quality and safety aspects. One of the things I wanted to pull out particularly was the increase in the friends and family test, and also the implementation, the rollout of the SMS texting. Really exciting to see how MSK services have taken this forward, and having some sort of fantastic results and feedback. And we just want to learn from that across. So I don't know if there's anything else in that, Linda, that you'd like to add from quality perspective.
Well, there's nothing else to add, and nothing stands out from this report. Thanks. Okay. And then finally, just we know our key sort of risk concern areas. They are very well rehearsed and deep dived, if that's a terminology, within our committees. And we will continue to do that, but it just gives you some of the detail behind the work that's happening with some of our areas of concern. So I think that was all I would really say, apart from, you know, we'd always take feedback on the development of the report. It's pleasing to see the development in the strategy, transformation and partnerships area, and we've got other areas that we are next moving towards. Thank you, Krishni.
Thank you, Anne. So Joanne, please.
Thanks very much. Thanks, Anne. I mean, this report is evolving really nicely now. I mean, it's such a rich source of information. Just a couple of tiny points for me, because as you say, the key areas where the concerns continue exist are particularly on some long waiting times. And it's just a question to see whether there are a detailed understanding of who are in those waiting lists. Do we profile the waiting list at all is my first question. And then secondly, and I don't know whether I'm straying into the operational space here. If I am, please push back. But is there any correspondence or any correlation done between those areas of our services where people just don't turn up for their appointments and extremely long waiting times? Because we don't really see that data flying through this information. So I'll just leave those two with you. Thanks, Anne.
Shall I come back on that, Krishni? Is that okay?
Yes,
yeah,
please, if you wouldn't mind.
Yeah, I think the work in the waitlist management committee is essential to this. So we have a deep sort of profiling of all of the waits that we have within our services. That doesn't just happen in one committee, that happens across the month, where the data validation team will go through continuously the lists of waits, work with services, particularly on any data quality, if any trends that we're seeing, any changes we're seeing, and also bring through to our clinical harm review process anybody who's waiting where there could be clinical concern, which is done in collaboration with Linda's patient safety team. So there's a real triangulation between, you know, performance, quality, safety of what we provide. So that is an ever-evolving process. And we respond not just to the wait list, but also we look at DNAs, we look at clearance rates, we look at you know, what does that look like as an overall trust profile down to the very detail of individual patient level. And so that the data validation team hold that together between committees, and then they bring to me particular, we go through particular patient lists where there might be, so this month we did dietetics, and we would go through in detail with the service leads, the clinicians, about what's happening there, where we could make some transformations, and where we need to escalate or mitigate against risks. So it's an ongoing process through the waitlist committee, which obviously we then report into performance to just sort of keep that narrative very clear for people.
Thanks, Anne.
Thank you very much. Okay, Julia.
Thanks, Krishni. It's just a quick add-on to that, really. I think overall reflection about the different elements that keep coming through every month around some of our services. It feels this time there is some positive change coming. Certainly the system review around community paediatrics, we very well understand the issues, the challenges, etc. We've looked at them in various committees and looked from quality angles and performance angles, and supporting the staff. But actually, it does feel as though some change may well be coming. And just the last bullet point around adult ADHD services, there's been an item on the national news this morning about people who wait a very long time. And again, it feels as though there's some movement there with new staff and embedding new staff. So it does feel as though there's some beginnings of some change from rather, static positions where we understand, but actually it feels as though there's, actions happening for the future. So that's great. Thanks.
Thank you, Julia. Anne, did you want to come back in on that?
Yeah, just to say, we also look at the profiling when things come up nationally. I think something came up on long waits the other day. So I'm able to pull data, understand what that means, look at where we are sitting, and very much it's very much down to a patient level of long waits and where waits might creep in. That's often data validation, but that's really key that we're on top of that straight away. But really keeping alongside that national narrative, so that we are clear what our position is, and that's what we're always keen to report back.
Thank you, Anne. Paul?
Yeah, just very quickly, Krishna, I just wanted to update board in terms of where we are on the back of month 3 financial position. So Judith mentioned it in the previous item, and obviously it's in this report too. So it's just we did have a plan to be in a deficit at this point in the year anyway of £1 million, and we've got a variance of 1.5 million, 1.6 million against that. So I just wanted to clarify that, to update the latest position. In terms of mitigations, though, for it, again, Chris has mentioned an awful lot of work within the workforce arena, as you would expect, and particularly around medical locums, as Chris described. We think there's a real opportunity for us to move forward with that from a costs perspective, and get those posts filled with substantive folk, and putting the right incentives in place to do that, I think, is going to be a big part of what that does. That also links back actually to our mental health outflows as well. So again, there are some things that we've recognised that are interlinked within our financial position that we can deal with within that piece of work. And also through the value programme as well, we think that in the month 4 position that it's vastly improved, and we bring forward a number of mitigations into the month 4 position, which again will start to move us away from that deficit position and back much closer towards the plan that we need to achieve of break even by the end of the year. So I just wanted to clarify that, Krishni, from the last 2 items.
Thank you, Paul. Helpful additional points there. Okay, if there are no further questions, I think we are asked to note the report, and we've obviously taken the opportunity to review particular areas of risk around waiting lists and indeed staffing concerns or questions that have arisen. And really good to hear some of the developments around stability. I think stability index sounds interesting. I won't try and unpack that now, but I do think that sounds like a really interesting area of development. So thank you, Chris, as well for that, and thank you, Anne, for your input. We move on then to the quality section of our meeting. So we start with paper K, which is the AAA report from the Quality and Safety Committee. Over to you, Julia.
Thanks, Krishni. Thank you, everybody. We'll take the paper as read, but just a couple of points to highlight. In the advised section, there's a number of areas of escalation that we've outlined from the Quality Forum to the committee, and we were seeking extra assurance around some of those areas. And just to add in, I attended last week's patient safety group, which reports in to the committee, and we heard a number of updates on these challenging areas, including some results now identified for monitoring low and no harm incidents that are being reported. And that's really important. Just to bring that to life slightly, we need to get the correct level of investigation for patient safety incidents to make sure that those that are graded appropriately, get say appropriate level of investigation. And just to say, from that meeting, we have 2 patient safety partners as part of the recruited as part of the National Patient Safety Strategy, and they're becoming much more involved and engaged in the patient safety group, which is excellent. So there's also a couple of updates on the concerns that we brought from previous reports in that advised section. One was around the scope of practice and some risk for our musculoskeletal physios, just to say that risk is now closed. And the other issue we brought in the last report was around GPs not prescribing to patients that are seen under a number of our services. And we were seeking assurance, which we received in the meeting. Patients do receive their medications and there are ongoing discussions. So it's not that people are left without their prescriptions, but just to update on those 2. Just to say, the focused assurance session for risk was around our safeguarding strategic board assurance framework risk. And I've highlighted there some of the conversations, mitigations and actions, etc. And definitely an improved position, particularly around system working, which is really good. And just to link this with Richard's point in the risk report earlier, we had some operational corporate risks considered alongside the board assurance risk relating to safeguarding, and that gave us a really richer understanding of the main strategic risks. So we saw that in operation, which was really good. A number of important documents approved in the Assure section: quality account, carers strategy, and some health and safety related annual reports. Just to say, there were no actual changes to scoring of our BAF risks, and the outstanding practice, can't leave without that. There was a definite theme with these 2 areas of multi-agency working and the impact and what can be achieved when we work together. So those 2 examples, just wanted to bring those 2 to life. So that's our update. I'm happy to take any questions.
Thank you very much, Julia. Very comprehensive report from the Quality and Safety Committee, as ever. And really good to see that, you know, it's there are no things that the Quality and Safety Committee are alerting us to. I mean, obviously, if there are things to alert to, then that's important for the board to be aware of. But lots of, I guess, positive assurance included within the report. And really good to see the celebration of good practice around the suicide prevention SOFA campaign, which I remember reading about, I think. So it's good to see that. Any other questions or comments for Julia on that report? No? Okay, thank you, Julia. We will receive that report from you and note the updates you've provided. So we move on then to paper L, which is the Patient Safety and Learning Assurance Report. So Linda, over to you, please.
Thank you very much, Chair. I will take this paper as read. Also, to provide assurance to board, this report was presented to the Patient Safety Group last week on the 18th of July. Just wanted to make note of our top 5 safety issues and how we've now set up a new category for recording the nasogastric restraint to feed, the planned interventions. So we've worked with our restrictive practice lead so that we've got a category that includes this specifically, because it is a restrictive intervention as well. So we took feedback and discussions through quality and safety around getting more information on these and understanding it. And this is where we are now going to categorize it and continue to monitor these areas. I also wanted to just highlight within the report all the ongoing work around our review of significant events. So you will note that we have less patient safety incidents that we are investigating, and that's in line with us moving to PSERF. So the discussions and reviews continue, the learning continues, and what's been really useful to see is the services coming together really quickly to implement any actions that need to be put in place immediately, whilst any incident that needs further review is still being reviewed. So that process is now embedded and really robust, and we're pleased to say we're getting a lot of engagement from services, including more junior staff that we wouldn't have seen previously in our internal assurance meeting, which is what we had before we moved to Rose meeting. The last bit that I'll just touch on is the information that we provided on our learning from deaths and our duty of candor reporting. As you will see, this information shows what has happened insofar as any deaths that have occurred. Our leader reviews, and we provided that information. Like Julia referenced earlier, we need to get the right level of investigation completed so that it's robust, and a lot of these will require a certain level of clinical skill and knowledge to do that. So provided some information on our thematic reviews and how these have been allocated, with some still in the phase of allocation, but just wanted to provide the assurance that we do need to get the right level of clinical skills, expertise to then lead this work. I'm happy to take any comments or questions, Chair.
Thank you, Linda. So anything that colleagues want to raise from this report? And this is the same meeting, Julia, that you went to, I'm assuming from your reference earlier. And actually, perhaps, can I perhaps just raise a couple of questions? And actually, one is more an observation. I think historically, I remember some time ago that there was a bit of a concern around from the CQC many years ago now around restraint, and I think we've done a lot. It seems to me we've done a lot of work to kind of make sure we're really clear the purpose of what, you know. So it's some planned intervention. So my reading of the description on you know, yeah, the sort of on page 1 about being really clear what the purpose of these interventions, I think has been really helpful. So the question I had was, and this might be difficult to answer, but is restraint for unplanned restraint now relatively low in the organisation? Does that make sense? I'm kind of taking the data that has been presented showing all the things that are planned and saying, well, is there anything that tells us that actually the unplanned restraint levels have reduced? I don't know if anyone can comment on that. That might be too specific a question. Linda?
Yeah, I'll comment on that one, Krishna. So with regards to our restraint, we've certainly seen a significant decrease in our planned intervention of using restraint, because we work with the service user, their carers and families to understand when you are in distress, how do we best support you? And some of that, it's actually the patients who then lead us to say, actually, I would want you to stop me from then assaulting other people or doing harm to myself. And the only intervention to do that, if de-escalation has failed, will then be to restrain. So when we look at the unplanned side, as you said, unplanned, it's one of those uneventuals. And what we do try and do as much as possible is de-escalate. Unfortunately, where we will have people that come through our 136 suite, you can't plan for that. We've got people who are very poorly in our psychiatric intensive care units, and again, you can't plan for that. And actually, where an unplanned intervention is used, what we focus on the most is that it's for the shortest time possible, and we also ensure that the patient is supported immediately after that and staff get their debrief. So we've done a lot of work around that, which then means for most of our staff, we would be leaning and relying on de-escalation before moving to an unplanned intervention. So whilst I can't say the numbers have decreased, I can certainly say the practice that's applied has significantly improved. And we're seeing that from the reports coming through.
Thank you, Linda. That's really helpful. Thank you. Julia.
Thanks, Christy. I just wanted to add in two additional pieces of assurance. One was around the patient safety group, and the one of the main focus areas is always learning. And just to say that most meetings, we look at a serious incident, we get the full report, we have opportunity to discuss question, etc. Always open and very honest, open reporting, and the thematic reviews, which are really important. So lots of learning happens, and then that's shared and cascaded through our usual routes. The other thing is just to say that patient safety is quite a big component of our early warning sort of data triangulation meeting. There's a weekly meeting that happens with a variety of trust experts and operational colleagues, and I dipped in last week just to sit through and just to fully understand how it all connects together a bit more, and incredible level of detail. And the assurance I gained was that the trends are being looked at, but also the information underneath. So getting underneath very early on in week 1, week 2, looking at what's been happening and what themes are going across different services. So just wanted to bring that out as 2 different areas of additional assurance that go alongside this. Thanks.
Thank you, Julia, and really good that you've taken that opportunity. I did see that in your list of activities, so it's interesting to get some insight on from you on your experience of that. So thank you very much, Linda, for the report. Very comprehensive as ever. Great that Julia was also able to be at that meeting and provide some additional insight. And clearly this is an ongoing area of focus, isn't it? The work on patient safety doesn't stop, but there's a huge amount of activity going on, and very much getting a sense that there's a strong grip on how we address these things. So thank you very much for the report, which we note and can take some assurance on, I think. We move on then to paper M, which is workforce safeguards. So back to you, Linda, on that.
Thank you, Krishni. Again, this report was presented to the Integrated Assurance Committee, and I'll take it as read. Some of the information here will be a duplication overlap to the information that has been presented or will be presented through the report that Chris Oakes brings in on workforce. So this has been looked at from a patient safety lens. So we are alerting on our number of vacancies, but also wanting to provide some assurance that a lot of work is being done insofar as recruitment and actually attracting people into the organization, including our own growth, our own pipelines with our apprenticeships. Within the report, mentioned that there have been 0 framework usage in June, and that's specifically to nursing, not the other clinical professions. So I just thought I should highlight that bit as well. And a lot of work has been done to move us from using a framework agency in nursing, and that's cascading across into the different professions, which is something that Paul discussed earlier and also Anne mentioned. We've had really positive feedback, and certainly we can see it through the work that's being done from mobilizing our internationally educated nurses, and that's been included in this report. And just to mention the different areas that they are working in, and that seems to be really well embedded and well received by our services. And certainly the reports coming from our internationally educated nurses, I'm sure that's the same with our international medical graduates, is that they're having a really positive experience and feel really supported, where we've got a pastoral support team in place also working with them. I'm happy to take any comments or questions, Chair.
Thank you, Linda. Anything that colleagues would like to raise? So we've clearly touched on sort of workforce resourcing through the meeting, and it obviously remains an ongoing focus. So as Linda said, there's a lot of these themes have perhaps been covered. So if there are no comments or questions, I think then we're happy to note that update, Linda. Thank you. And move on to paper N for the final report in this section, which is the AAA report on complaints PALS, feedback and involvement.
Thank you, Chair. So following feedback from colleagues where the report was presented differently, we've taken on the AAA approach, and hopefully this is clearer on the areas that we need to alert, advise, and also provide assurance. So whilst we've mentioned that for our feedback, particularly, we've seen an increase in the feedback, but actually the wider rollout of SMS text messaging will see an improvement in that. And what's delayed it was around our consent. So the consent that we previously had was one where all the patients would say, yes, I want to complete this, but actually the one that we should be working with is an opt-out one. So DTS have been very supportive, and our information governance team in setting this up. So we're likely to see a significant improvement once we've addressed this issue. With regards to our involvement, we clarified that for colleagues who do work with the Recovery College, which supports our patients, those with lived experience, our experts by experience, back into employment, this does not fall within our reward and recognition process. So that would not be included within that. And ongoing work just to separate those issues so that our involvees fully understand it, because there are implications of worker status once someone is taking on more work as opposed to involvement. We provided a lot of information here around our complaints, PALs, and whilst we did have some cases that we did not meet our target insofar as getting back to the complainant, a lot of work has been done around this. So we've increased the capacity of those who investigate complaints. And some of the issues that then come up is on allocation. A case is allocated to an investigator, and then when they do meet with the complainant to progress it, unfortunately, they find that there's a bit of a conflict because we do have patients who change their names, so you wouldn't immediately recognize that, and then that leads to some delays. Other things are actually getting the information and ensuring that the complaint is really robust. We do have those complaints that just do not involve NHFT, they involve other system partners, so that also presents a layer of complexity. And we do receive those complaints with a lot of information, and it takes quite some time to tease out what the issue is. But throughout the process, we maintain contact with complainants, and we try to resolve the issues even though the complaint is ongoing. The last bit Anne had already mentioned, which is an increase in our friends and family test score. So we're seeing an improvement on this, and we certainly want to see that continue for the rest of the year. So I'm happy to take any comments or questions.
Thank you very much, Linda. Yes, it's important to note that friends and family test position, I think. Any questions for Linda or comments really on the report? I just wanted to check, Linda, just on the point around the involvement and the sort of differentiation. I think the original, if I'm right, and Paul may need to comment on this, one of the drivers for changing the process around recognition and reward for people on involvees was something linked to HMRC and that kind of, I think you referenced it as sort of worker status, wasn't it? So are we comfortable now that whatever arrangements we've got in place not only appropriately reward and recognise our very valuable contribution that involvees make, but also are compliant with our, our obligations in terms of HMRC? That might not be a question for you, Linda. I don't know if Paul or somebody else can comment.
Yeah, happy to, Krishni. As far as the work that Linda has led in this space, it was always to ensure that we retained the valuable input from involvees across the trust. That was always one of the things that we were most worried about. But yes, it was always done then to comply with HMRC. As you say, that was the kickstart, the driver. And I think from memory, about 4 years ago, we had a review which sort of highlighted the risk that we had in that position. So definitely something that we've been able to do over the last period that Linda's led to make sure that we can continue to reward involvees in the appropriate way, but also not put them or the trust at risk of making sure that we get the taxes correct.
Right, thank you, Paul. Linda?
Yeah, I just wanted to agree with what Paul is saying. So when we started out this process, we were mindful that we have involvees who do not seek any form of remuneration. So when we look at some of our involvees in our secure settings, they wouldn't get any form of remuneration. So we needed to have that really clear and have those stages that people can understand, that you can dip into involvement and then take a break from it. So there was a whole wide piece that we're doing. So certainly I can confirm that what we have in place now meets our statutory requirements from an HMRC perspective. And this particular piece of work was also part of an audit action. So we were reporting to audit committee, who then signed off that this action has now been completed. So we have complied with that. And certainly, as Paul said, we are working with involvees to ensure that we retain them and attract more involvees. Thank you, Chair.
Thank you very much, Linda. And on cue, Saqib would like to come in relation to, I'm sure, the scrutiny of the audit committee on this. So Saqib.
Yeah, so I was just going to comment that the involvee payments had been going. I can't recall, Paul, whether it was even before you had come back into role. So I think it had been going for quite a substantial time. And the only thing I was going to ask, one of the impacts that we thought might happen was people that were on benefits, they may be worried what the impact might be on their receipt of benefits. So I just wanted to know, do we know if that affected anyone stepping down, or was there a way that we got, I don't know, not round it, but compliantly with HMRC, that a person could carry on and it didn't impact on their benefits?
Linda, do you want to come back in on that?
Yeah, so part of the work we did, Saqib, was to actually engage an organization that would provide that advice around benefits, because it's individualized and we couldn't take that on. We're not the experts. So we've not had an involvee come back to us to say it's impacted me here, because that support was put in place and really clear, and people understand the levels of work that they can get involved in. So we did provide support, and it's ongoing. It's still there for any new involvees who will also come into the process.
Thank you. I mean, the charity I'm involved with, they were discussing making payments to people to get involved and stuff. And it was suddenly, oh, I've got some experience in this. It might not be something that we necessarily want to consider.
Thank you very much, Saqib. Okay, so helpful. And I think when Linda, you've helpfully reformatted this report, I think I saw some nods around the room around the development of this report. So thank you for taking that on board. And I think it does help to sort of highlight issues to us that we need to be brought to our attention. So really appreciate that work that you've done. Okay, so I think that brings us to the close of our quality section, and we are a little bit ahead of time, but I'm hoping that Beth is with us or due to join us momentarily, because we are taking our Freedom Speak Up annual report, which is paper A, a very important report that we as a board, I think, need to really look at carefully. And I'm pleased to see Beth on screen. So welcome, Beth. Nice to see you. And we are just introducing paper O, which is your report, Beth. I think we'll need to take it as read, but obviously you might want to highlight some particular things. It's a very comprehensive report, but I'd really like to leave some time to make sure we've got plenty of time to ask questions, because I'm sure there will be many, if that's okay with you, Beth. So over to you.
Perfect, thank you. So we will take it as read. I've summarised on page 17, which I hope is helpful. It continues to be a busy year. Staff are continuing to speak up. We've created a schematic report with HR and staff side partners, which we hope that will provide a consistent approach to speaking up and embedding speaking up in everyday life. I'm grateful and supported by my exec and non-exec colleagues who hear, support, act, and our invaluable support from my other Freedom Speak Up guardians and LPT. I think there's one point to change or add to the report. So on page 17, where I've listed the key actions as a priority for 24-25, I've talked about that I report into the Integrated Assurance Committee, but I haven't actually added that I also report into Senior Exec Board. And currently I report into Senior Exec Board on an annual basis prior to the annual report being presented. and it was a really important discussion where I share much more in-depth information to the exec colleagues, and just for your assurance is that everybody was aware of what the concerns were, what the themes were, and that we were acting on them. So after this meeting, I'll add that into the report. And just in addition to new information, we're currently being audited by TIA. I've found this a really supportive process and have now submitted all of the evidence that they've requested. There'll be a further one meeting with me before they provide their feedback. There's just some initial feedback that they've provided on encouraging the take-up of listen-up and follow-up training, which we've already started to do within the organisation, and learning lessons, which is going to be difficult for me and other organisations, how we get that key learning that people are sharing their concerns about, how we're actually not just managing that within the area where the concerns are being managed, but how we're expanding that across the organisation. And just for your update, that we had the review of the self-reflection planning tool last year, and we had the 2-year actions. I've got the actions that are within the report at page 17. And there'll be an updated report that comes to Integrated Assurance Committee either in August or October of the progress that's being made currently. So that's all from me really to give you as information, and happy to ask questions.
Thank you, Beth. So any questions that people want to ask Beth? Linda?
Thank you, Chair. Mine is not a question, it's really a comment. So thank you for pulling the report together, Beth, with some really useful information. I just wanted to make mention of the healthy speaking up culture. We're seeing more staff raise their concerns openly. So whilst we also have staff who raise these confidentially, when the Freedom to Speak Up Guardian has then gone back to them to say, do you consent to me sharing X? We then see those staff saying, yes, I'm happy for you to do that. So for me, the report does evidence that healthy speak up culture. Thank you.
Thank you, Linda. That's very true. The open concerns are increasing, and we hope very much that we can get people to speak up and share their concerns, and we can do the review with the follow-ups in 3 months and 6 months where people have felt confident that that was the right course of action to take, that they were listened to and heard, and that there was no negative impact that follows that, which is obviously what people worry and are concerned about speaking up in the first place. So thank you.
Thank you, Beth. And thank you, Linda, for the additional observation. Angela, please.
Yeah, just to say a thank you to Beth for the work that she does. Obviously, I work closely with Beth on this, but it is a really important role that we've got within the organisation. It's not ever always an easy role, but I think it's done with great energy, and Beth really does make sure she's championing the issues, which I'm sure all staff would want to hear. As others have said, I think we've got a healthy speaking up culture, but equally we shouldn't stay complacent. We've got to make sure that we do understand where we're not hearing from services, and to make sure that we understand that that's not because they're not inclined to speak up. They may be using other routes, as Beth said, so we just need to make sure that we are doing that. It's encouraging that we've got champions across the organisation. That does help, because those local connections give more capacity, but also hopefully some sort of sense of it's okay to raise these concerns, and any door is the right door. So that's really important. I think just to remind the board that as well as myself and Dave meeting regularly with Beth, so we can triangulate what's coming through and take action, Krishni, myself and Melanie also meet regularly with Beth to understand that sort of strategic view of what's happening, so that we can make sure that we are thinking about how we're working as a board in relation to this as well. Thank you.
Thank you, Angela. Judith, please.
Thanks very much, Krishni. Beth, thank you very much for another really comprehensive report. I did actually put into the commentary that just yesterday at the NHS Providers Network, there was discussion on the real importance of freedom to speak up. So I always very much welcome your report. But just a sort of question arising really from your report. there has been some feedback from governors that they feel that from staff governors that they feel that then there should be more freedom to speak up guardians. So I would very much welcome an understanding of the future work that you have planned for the coming year, so that because as Angela said, this is constant ongoing work. We're never done with this, and we always need to be aware that there may still be voices that we're not hearing.
I think that's really helpful, and I think that's true. There's areas of concern where people would like more visibility, and whether we can support that with the Freedom to Speak Up champions. We are increasing, and we hope to continue to increase in the areas that we're not hearing from. The important part at Senior Exec Board we were talking is it's not just about the areas that we are hearing from, it's those areas that we're not hearing from, and why are we not hearing from them. That's absolutely fine if their complaints and SIs are low. Staff survey is great, but if there's areas that staff survey is not so positive, and we are hearing about clinical reviews and complaints and SIs in these areas, but people are not speaking up. So that's my task, and we agreed that we would go back more regularly to Senior Exec Board to share what those concerns are and how we embed those out. So visibility is key. So I take that on board. The champions will help me with that. And I was going to say something else, and obviously we've got Freedom to Speak Up month that will be coming up, so we're starting to plan with that, and hearing about people that maybe there are barriers to not coming forward. You talked about the NMC report, so I was here in the background, so I listened to Trust Board because it really helps me inform my work. So we talked about the NMC report, and as part of that I've reached out to both Mo and Amelia from our Reach staff network to say this might be a really good point again to continue and come back again to talk about speaking up and about the barriers. And I've also reached out to Katie Riley and Joe Selby Green and Pauline Nyatakawa to talk through what those challenges might be for our staff bank members when we're going into the processes, because you talk quite rightly about having the meeting that we talk about whether people go into those processes, but what more that can we be doing to reduce those barriers for people.
Thank you.
Thank you, Beth. Julia, please.
Thanks, Krishni. Thank you, Beth, for another full, very, very comprehensive report. And I'm always staggered by the amount of work that goes on, to feed into our culture. But when I was reading the paper, I was reflecting very much about culture and the open nature of our organisation. And there's a couple of points that just live and breathe it for me and mean that we are really genuinely open and want to learn and listen and learn from our staff and others. So talking about that, we have got above the national average for questions relating to freedom to speak up in the staff survey is great, but then you then go on to say, but actually there's more to do, and we want to understand, especially in areas where people don't speak up. And just one other thing, it was good to see you talk about some themes and actions for areas that aren't formally required to be reported to the National Guardian's Office, and to sort of get the completeness of all those themes. I want to just sing that out because that's really important. It's getting underneath. We're not ticking a box looking at just the areas that have to be reported. We're looking at it all and taking it seriously. One thing I'm looking forward to over the next year is strengthening the connection with Quality Committee. Now the oversight sits with the Integrated Assurance Committee around patient safety issues that come up, and I know we do have that, but we're going to try and look to strengthen that through the reporting and through looking at our issues over the next year. That'd be great.
Yeah, I think that's a really important point, because I've started working with Linda on that. I report into the Integrated Assurance Committee, and that's more about the worker leadership behaviours. But now the patient safety and quality concerns, have we got that right? So I'm going to the Patient Safety Committee. Is that right, Linda? Or we might do that as part of a report, but there's definitely some work that we can then centre the worker safety and leadership behaviours with the patient safety quality, so that we've got that all right coming through to quality and governance. Is that right, Linda? Is that what we agreed? I think.
Yeah, that's right, that you will be joining our patient safety group, because that's where the discussions are being had, and you can triangulate the information from there.
Great. Thank you, Robin.
Beth, thank you for the report. One of the areas you highlight, and you sort of mentioned in passing, but without precise detail amongst the groups who are not represented in as fully is particularly staff from ethnic minority groups. And this came out very strongly in a discussion in one of the recent governor meetings as well. Can you say a little bit more about how we are going to ensure that there is greater representation amongst people from ethnic minority backgrounds and greater involvement?
Yeah, I can. So I'm working closely with all of the staff networks. So all of the minority groups that we know that might have more difficulty in speaking up. So there's definitely strengthening our staff network relationship so that I can understand what key themes are coming up through them, what's coming up through us. We currently report into the Diversity Network Leads meeting about what those challenges might be so that we can triangulate those. And when we was talking about the triangulation, it's those areas that we're not hearing from. So I've started to pull together a report from what we're hearing from the staff survey, what are the top areas that we need to be focused on around health and wellbeing and safety and quality for not speaking up. And then looking at, we have a weekly triangulation meeting, which looks at which services come up regularly as a repeat offender across the board. So that could be anything from patient experience, staffing issues and safeguarding and health and safety issues that are coming up. So taking that report, taking the staff survey report, taking what I'm hearing as well, and then working with organisational development to make sure that we are focusing on the right areas for support. So that's the work that I'm doing in the background, as well as just working with the staff networks and increasing champions within our staff networks so that people can go to. Every team meeting or training session that I go to, I talk about the role of the champions and how important that is. And just on Tuesday, I was at a session around older adults, and two people came forward to talk about it. It was really important, really interesting to hear about speaking up. We know about it, but we don't really understand what the intricacies of speaking up are. And yes, I'd really like to be a champion. So we're going to increase the champions in those areas so that people have got a voice, to make sure that the champions are aware of what those boundaries are, because the National Guardian Office are really clear that the champions don't take on the roles of a guardian, that they're there as an ally, that they're there as signposting, that they're not there as case handlers. But it's really important that people speak up to many people as possible, because what the champions can capture is those key themes of what we're hearing and what are we doing about them, so that we can look as a whole, how do we need to improve within NHFT? Does that help?
Krishni, can I have a follow-up, which is, I mean, amongst the champions, which are obviously a very, important group, is there a kind of good representation from staff from ethnic minority backgrounds in particular amongst the champions?
There is, yes. We can increase them, but there is an area of representation. Yes, there is.
I think the report, yeah, so, and it was a particular area of focus, I recall, when we actually managed to increase so I think there are 7. I don't know if that's still right. Is it, Beth? You mentioned in the report that
it's
there
in
are
the
7.
report. I think I've put in the report.
Yeah,
That's as it stands.
Yeah.
And when we think of how many champions there are compared to how many staff they are, it would be really helpful to increase that significantly across all groups, ages, demographics would be brilliant.
Yeah. So currently 40, just based on the report you provided, currently 40 champions and 33 white staff, 7 cultural and ethnic minority staff. But certainly I know, and Robin's point is an important one. I do recall some time back when we first really increased the champions from an ethnic minority background, it massively increased, didn't it, the number of concerns that came from ethnic minority staff. So I think that's people feeling confident about being able to use freedom speak up is really important. But it also worked well. I'll come back to the point. I know there are a couple of people wanting to come in, but I was going to make a couple of points myself. But I'll bring Linda in first. I know Linda's been waiting, and then Angela. Linda.
Thank you, Krishna. I just wanted to add a few more points to Beth's response to the question that Robin raised with regards to our governors and colleagues from ethnic minority, global majority not speaking up. So one of the things that happens in NHFT is that staff do speak up, but unfortunately, it's not everyone who recognizes that this person has spoken up. So for us as execs, fortunately, this year we did have a session on speaking up, and we then started to understand that as the member of staff has said this, then actually speaking up, which we wouldn't have blogged it or even noted it as that. So when Beth has said she's reached out to the co-chairs of the REACH network and other networks, that's key. Because when you look at the action log, the case tracker, incidents reported in REACH network, it's really long. There's a lot that goes into that. And certainly the co-chairs are doing that work in recognizing that this is Speak Up. This now needs signposting to the Freedom to Speak Up Guardian. So we do hear from them, but not necessarily that they've come through this route to raise their concern, which is no different from other colleagues in the organization. Our white British Caucasian colleagues, they speak up as well. It could be to a senior colleague, it could be to a manager. So there's a lot of work in supporting people to recognize Speak Up. And a lot of that will be led through having more champions, because then it's cascaded at a local level and people start to understand that even more. So as the work goes on in triangulating and the signposting from the networks, that will provide further assurance into hearing the voice of ethnic minority colleagues, which we already hear because Beth is in constant contact with network leads and attends the quarterly meetings for that.
Thank you, Linda. Angela?
Yeah, no, I was going to make a similar point to Linda's in respect of those other data points, if you like, or other ways, but also just to share with the board that I also then meet with the co-chairs, Amelia and Mo. I think it's either monthly or 6 weekly and they may give me things directly in that. So it's making sure that they understand and feel that they've got that direct route as well. And then I also meet with them and the co-chairs across LPT together so that we can understand that piece, so that we're just encouraging that any door and trying to gather as much as we possibly can, which but there's always more to do. And I think the champions is the way to really sort of try and strengthen that further. Thank you.
Thank you, Angela. Couple of things from me, really. First of all, Beth, I just really wanted to congratulate you for the feedback, because I do think that the feedback that you have got, I mean, I don't know, the evaluation and monitoring feedback you've got, that those do look positive, particularly the interactions people have had with you, and hopefully, that gives people confidence that they would be able to say, well, I had a good experience. I mean, not everybody does, clearly, or people have, there's some don't knows in there, but actually it's when people have had the confidence to use it. I think there was something we said, well, I don't know why I didn't do it before. I think I read that somewhere, which is really positive, isn't it? So using that to help people feel confident is really important. So I just wanted to really thank you for that and congratulate you and colleagues who are involved in making sure that happens. The thing I was curious about, Beth, is in the past the National Guardian's Office has done an index, a sort of Freedom to Speak Up index based on the staff survey results. I know you've shared the staff survey results, but are they carrying on doing that, or have they stopped doing that?
They've stopped.
Okay, which is a little bit of a shame, because I always found that quite useful as one measure, one single measure, but there you go. And the other thing I also wanted to sort of mention really was that I think it's there was just an example of something. I won't go into the detail, but I was out visiting an office, and I was talking to a member of staff, and things came up from both of those, and I reached out to Beth just to say, Beth, can you help? What was encouraging, and as I say, I won't go into detail, but it was things I overheard and things I was told by a member of staff, and I contacted Beth and said, Beth, are these things that you can help with? And it was really good. It was reassuring to me. Beth had already had some awareness of issues in relation to some of the colleagues or services involved. And it just felt like a route that enabled me to feel a bit more confident that we could at least look into some things that I hadn't had a formal concern or anything raised to me, but it did feel important that that vehicle was there. So thank you, Beth, for helping me out on those occasions. But it is important for us to recognise the role that Beth can play in those situations. So if there's nothing else, I think it's really great that we've had that opportunity to explore that in a bit of detail, Beth, and give you a good chunk of time on our meeting. Great that you're always observing and coming to the board, I think, when you can, so that you've got a sense of what's on our agenda as well. Anything you wanted to add before we close?
No, nothing at all. Thank you.
Thank you
for
very
all
much.
of your support.
Thank you.
Thank you. Thank you,
Okay.
Beth. And keep up the good work.
I will try.
Okay, so a really important report for us to receive and of course and take assurance from, but there's always, as Angela said earlier, more work to be done on this, and that sense of kind of creating confidence in our culture of speaking up and people feeling safe to speak up is really important focus, ongoing focus for us. So moving on then to the next section of our agenda, we have first and foremost, we have the AAA report from the Audit Committee. So Saqib, over to you.
Yeah, I noticed that we've actually got two this month, because I was going to comment that we'd had one in between, but you have two AAA reports. As I've highlighted on the advise on the data protection, so that's something that we'll have to continue to watch. And I think obviously with the change in government now, then I think areas like cyber, etc., will be an area to ensure that we're up to date with, as I'm sure we would, but also GDPR. After Brexit, I think there was commentary that that would be an area that would be revised, because GDPR in its current form had come in while we were members of the EU. So we'll see how that evolves. The other things that obviously have been rehearsed at a number of meetings of that we had green in our counter fraud, that we had a head of audit opinion that was signed off, that our accounts were submitted. And obviously I've thanked in previous forums the hard work that was done to get us over the line, both with our external audit that was done. And then on internal audit, some of the reviews that are presented there, that you can see recommendation to tighten up on some of the work on Barclaycard was one of the areas that I think something that I've always been very conscious as a audit chair and organisation that I work with, that we shouldn't just look at areas that we're confident that we're going to get good findings in, but areas that we want to improve in. And I think this was an area that we knew that we could improve in. So I think, you know, the reasonable assurance reports that we've had and the work that's done on this, I think, will show that we're continuing to evolve in that theme. There wasn't anything particularly else that I wanted to add, but obviously I have put the celebrate as outstanding on the second one of the counter fraud standard. And so I'll leave it there, but happy to take any questions.
Okay, any questions or comments? Both pretty positive reports, Saqib, I think. So, you know, again, positive assurance, I think, to get from the committee. So thank the committee, as we did with the previous committees, for the assurance provided in a number of areas. And also noting, you know, the really positive areas like counter fraud, which I think has been an area of focus in the past. So it's good to get really positive assurance around counter fraud, because it's not always been possible to get that, I think. So welcome that very much. So thank you, Saqib.
Yeah, so we've got great partners. So you know, I think we're very, very lucky in that respect. Thank you.
Great. Thank you very much. So we note both of those reports from the 24th of May and 20th of June. and thanks to the committee for the report sent to Sakib. And then finally, we have the paper R, which is the highlight report from the joint working group. So Julia, over to you.
Thanks, Krishni. So this is our joint working group with Leicester Partnership Trust, co-chaired by myself and Faisal, the Deputy Chair from LPT. And just to let people know who are not sure of what the group does, this is where we come together strategically to two organisations looking at our joint programmes of work. There are 9, and over the last couple of meetings, we've reviewed the progress in the last year of each of those 9 work streams. You can read the detail in the report. Importantly, each programme of work is linked to one of our board assurance framework risks, and they're identified for each organisation in the report. This time, the important piece of information is around the headlines roadmap attached at the end. And I think it just highlights the enormity of the work that's been undertaken over the last year. Huge added value for patients, service users, staff and our communities. And we've often talked about the hidden value, which is the learning and sharing opportunities and the closer working with our clinicians and others across both organisations, which again doesn't always come out quite clearly as tangible, measurable effects, but it has a huge impact. And we have lots of examples where people are learning and sharing together, which is really good. It also just updates us on our value programme. It's already been talked about in the Performance Committee report too, and the work that's commencing across both organisations to develop a group strategy. And that'll be our focus for the next 5 years, our strategy. So happy to take any questions or any comments.
Anything anyone would like to explore? I think Judith has agreed to join this meeting and in fact attended her first meeting. So, and similarly, Hetal will be joining from LPT as well, in the process of expanding our membership. But of course, we'll take the opportunity to review the feedback from the Deloitte Well-Led report as well, and in terms of developing the group's role. But we really enjoyed receiving that roadmap, didn't we, Julia, and kind of reflecting on that journey, because it feels like something that just captured really a lot of the focus that the group has had. So thank you very much. If there are no comments or questions on that, we are actually well ahead of time. So perhaps allowed a little bit more time for some areas that we didn't need in the end. We have got item, so we're obviously asked to just review and receive that report from the joint working group, so thank you for that. We are on to item 15, which is paper S, which is the declarations of interest, which is really just there for our noting in public, and just to remind colleagues to make sure that we do keep that up to date. Although I think it's been no doubt refreshed recently in advance of the new financial year, we are obligated to make sure everyone keeps that up to date through the course of the year. I'm not aware of any other business that we need to cover. So just an opportunity to ask board colleagues for some feedback on what we've covered on the agenda, any suggestions for improvement. Obviously, we've run ahead of time, which is quite unusual, but apart from that, any comments? Julia?
Thanks, Chrissy. I'm just reflecting on our patient and staff story and how really important it was to have some decent time to do that. It really helped our understanding of particular situations, but so much was drawn out of that was so valuable, as always. But actually, the value of thank you for letting that go beyond the allocated time, because actually that was really important and it helped us get a richer picture and understanding of the service.
Thank you, Julia. I was very conscious that it felt like, I think your observations around, things like the data in our patient safety and learning and assurance report, and then hearing the story that really brings that data to life. I felt that was really important. It was exactly what I was thinking when I was hearing it. So it did feel like they all are, in that particular instance, I think it brought an additional level of insight and understanding, as patient stories often do. And I was a little bit worried that I'd let it run on a little bit too long and I would struggle to pull it back. So I'm perhaps everyone's compensated and been kind to me since then, so that we've finished actually earlier than expected. So if there's no further reflections or feedback, I'll bring the meeting to a close. Our next meeting is Thursday, the 26th of September at 9:30. That's our next public meeting.